A very good morning to all. Please join me in standing for the national anthem. Good morning, everybody. Ladies and gentlemen, welcome to Bahrain, where our hospitality is matched only by the ambition of our healthcare vision. It's with the great honor that I stand before you today at the opening of the C3 Summit. As we gather today at this pivotal summit under the expansive theme of the evolution of global healthcare, we are joined by some of the finest minds from around the globe. These are individuals who are at the forefront of medical innovation, policy making, and healthcare administration. From the corridors of renowned hospitals to research labs pioneering future treatment, to the workstations of engineers leading innovation in healthcare technology and data analytics. Our speakers represent the diverse tapestry of global health industries. We are at a critical juncture in healthcare. The challenges of the past few years have not only tested our preparedness, but have also unveiled the vast opportunities for innovation and collaboration. As healthcare evolves at unprecedented pace, so too must our strategies and policies. This summit is not just a conference, it's a call to action. It's an opportunity to forge a new partnership, to learn from the global community, and to take home insights that will not only enhance the capability of our respective health system, but also improve the health outcome of our communities. Over the next few days, we will dive into discussions that explore the challenges faced by the region today, advancement in the role of governments and policies in healthcare, efficient healthcare delivery, and robust policy framework, and the role of technology in the progression of healthcare innovation. We will share knowledge and experiences that transcend borders, and we will work together to outline a future where health equity is not just an ideal, but a reality. Let us engage deeply and question critically, but also dare to dream boldly. As we chart the course of the future, your contributions over these days are invaluable. Together we can shape a healthcare system and landscape that is resilient, adaptive, and above all, inclusive. Thank you for your commitment to this journey, for your dedication to the health of the global citizenry, and for your presence here today with us. We look forward to the vibrant dialogue and the transformative initiative that will emerge from this summit. Let us embark upon this journey together. Please, the video.
Kingdom of Bahrain, the bridge between the East and the West, the story began. From a lone small clinic in Manama to a global model in healthcare, we narrate to you the historical journey of the health system in the kingdom and the tale of success passed down through generations. Over 120 years ago, in one of Manama's old neighborhoods, the first health clinic was established by Pastor Samuel Zwemmer and his wife, Amy Wilkes. This clinic eventually became the cornerstone for the American Mission Hospital. From its official opening in 1903 until the 1940s, it served as the premier health institution in the country and throughout the region. Today, with its multiple branches and clinics spread from the north to the south of the kingdom, it stands as a pillar of the national health infrastructure, offering top-tier medical care. Throughout the last century, Bahrain has continuously advanced its healthcare infrastructure, with clinics and major hospitals succeeding under the guidance of the kingdom's leadership, aligning with the global efforts to enhance citizen welfare. In 1957, Bahrain witnessed the opening of its first public and specialized hospital, the Salmania Medical Complex, offering diverse medical services to all citizens, residents, and visitors. In the south, the Bahrain Defense Force Hospital was inaugurated in 1968. In Muharraq City, King Hamad University Hospital was opened in 2010. In an exceptional collaboration, Bahrain inaugurated the King Hamad American Mission Hospital in Ali in 2023, becoming the fourth major hospital. Beyond these hospitals, a network of public health clinics spreads across Bahrain, part of an advanced and integrated health system, aiming to achieve the government's vision in line with Sustainable Development Goals, health for all. In accordance with efforts to enhance health infrastructure, Bahrain pioneered the establishment of regulatory and legal frameworks for the health sector, creating the Ministry of Health and the Supreme Council of Health. In 2010, the National Health Regulatory Authority, NHRA, was launched, regulating and overseeing the health sector to ensure quality and efficiency in both public and private health institutions. With these continuous achievements, Bahrain has established a strong partnership with the World Health Organization, now hosting its country office in the Kingdom of Bahrain. The future holds promising prospects for Bahrain's health sector, with global qualities positioning it as a leading healthcare center in the region. With a leadership committed to the welfare of its citizens, dedicated medical professionals, and strong international partnerships, the story continues.
It's my great honor now to welcome Dr. George Cheriyan, who is the corporate CEO and the Chief Medical Officer for American Mission Hospital, the Kingdom of Bahrain. Please, Dr. George.
Your Excellency, Sheikh Mohammed bin Abdulla Al Khalifa, the Chairman of the Supreme Council of Health, Your Excellency, Jameela bin Said Al Hassan, the Minister of Health, the Kingdom of Bahrain, Your Excellencies, distinguished guests from all over the world, and delegates, a warm welcome to the Kingdom of Bahrain. Ahlan wa sahlan. My thanks first to the leadership of this country, His Majesty King Hamad bin Isa Al Khalifa, and the Crown Prince and Prime Minister, Prince Salman bin Ahmed Al Khalifa, for their tireless support and the vision to transform healthcare for the residents of this country and for this region. The opening of the King Hamad American Mission Hospital stands as a testament to this vision. Thank you, Ransel, for your friendship that has gone for several years and your commitment to bring the C3 Summit to the shores of the Kingdom of Bahrain as the Davos of healthcare. So thank you, Ransel. The title of this conference is Evolution of Healthcare. And if you look at how human health has evolved over 2,000 years, And you would look at this 2,000 years, 2 millennia, and you will suddenly realize that most of the rapid transformation happened just in the last 200 years, in the 200 years. And then if you look at this 200-year piece, you will suddenly realize that the real transformation in health happened over the last 20 years. And what happened in the last 20 years? Internet, technology, human genomics, and the pharmaceutical industry, they have all transformed the way in how we look at healthcare. Today, we stand at another inflection point. And this inflection point is AI, generative AI, that will disrupt healthcare in how it is accessed, provided, and funded over the next 5 to 10 years. Health and healthcare is a universal global need that transcends boundaries and is delivered, and how it delivers matters to the communities that we live in. As we all know, pandemics respects no boundaries. And hence, more than ever, collaborations are essential for us to prepare for the next one. The spending on healthcare in the GCC is to increase to $150 billion in the next few years. With advancements in genomics, precision medicine, and AI, there are huge commercial opportunities in how future of health is designed and delivered. C3 works across all three domains: the commerce, the community, and the collaborative domains. One of the common problems that we all face universally across the globe is rising healthcare costs, changing patient demographics, evolving consumer expectations. New market entrants and complex healthcare technologies and ecosystems are all challenges, but they're opportunities as well. Healthcare stakeholders need to invest in value-based innovative care delivery models. What served us over the last 100 years is not going to sort of serve us for the next 20 years ahead. We need to look at alternative employment models, alternative training models in how we look to the future of healthcare. Globally, we have increased the lifespan, but we have not increased the health span. We're living longer, but unhealthy lives. This is the biggest challenge for the future of health. Patients are no longer passive participants in their healthcare. They're demanding transparency, convenience, access, and personalized products and services. Consumer experience matters to them just as margins are important for the providers. Globally and within the GCC, value-based healthcare has come to be one of the hottest topics that we debate. Fortunately, there seems to be a universal agreement to the definition of value. Michael Porter defined value as the outcomes that really matters to the patients, divided by the cost it costs us to provide this care. Neither the numerator nor the denominator have got any challenges. We all believe that. Donna Median introduced outcomes as a measure of quality in the 1980s. And the Kissig's famous iron triangle of cost, access, and quality formed the foundation on which most healthcare systems were built. From climate change to conflicts, healthcare systems are being challenged with rising costs and shortage of healthcare staff. Digitization and technology seems to offer promises, with increasing volatility and pressures on financial margins both in the public and private sectors. Over the next 2 days, as Dr. Jameela said, we have assembled experts from all over the world, leading experts that will dive deeply into the global challenges that we face, and to reframe the question of what is indeed the future of health. It is not about healthcare, what indeed is the future of health? And most of these solutions are going to be borderless. It doesn't define a geographic boundary, but it is health for all in the globe. I now invite my friend Ransel Porter to address the audience. Thank you.
Well, good morning. This is really one of the better mornings of my life, so I hope it works for all of you as well. My name is Ransel Potter, and I am the founder and the managing partner of C3 Summit International. And on behalf of the summit, the King Hamad American Mission Hospital, I am thankful to His Majesty King Hamad bin Aziz Al Khalifa and the Crown Prince Prime Minister Sheikh Salman bin Hamad Al Khalifa for their unwavering support that allowed C3 Summit to inaugurate the Davos of Healthcare here in Bahrain. I would also like to share my appreciation with Your Excellency Sheikh Mohammed bin Abdulla Al Khalifa, the Chairman of the Supreme Council, and of course, Your Excellency Dr. Jameela Al Sayed, Minister of Health. So thank you all, distinguished guests, for coming, and I appreciate the support and vision of everybody here to improve excellence in healthcare. All of this started back in 2012 when I first came to Bahrain to be part of the first Bermuda Bahrain Economic Forum while I was at Morgan Stanley. And it was here that I understood the importance of our countries being aligned in a common cause, which is healthcare. There is nothing more important than healthcare. And when I returned to the US, I decided to leave Morgan Stanley and to start an international healthcare summit, which I named C3 Summit, and that stands for Community, Collaboration, and Commerce. The mission also is one that I feel today is more important than ever, which is healthcare diplomacy, healthcare knowledge, the transfer of knowledge, and also, of course, the interaction of leaders that can bring solutions that are not just confined to a region, but are solutions that are borderless. And that really has been the mandate and the mission. So over the past 14 years, C3 has had the honor to welcome to this forum leaders in business, major hospitals, as well as the US State Department, the United Nations, which I'm proud to say now lists C3 as the first official side meeting in the healthcare category during UNGA, which is UN General Assembly Week, when the eyes of the world come to New York and focus on what we're talking about today, solutions and collaboration. In 2016, we gave His Majesty the King of Bahrain the C3 Lifetime Achievement Award. And in 2021, we awarded His Excellency the Crown Prince and Prime Minister the C3 Global Leadership Award for his steward leadership in guiding the kingdom through the COVID crisis. I also have been extremely fortunate to have many interesting leaders, such as President Clinton, who keynoted the very first C3 Summit in 2012. And at the end of that summit, I went up to President Clinton and I asked him for his advice for a startup like C3 Summit. And all of you know how he wagged his finger like that, and he said, Ransel, 3 things. He said, don't try and be a tsunami. A tsunami will surge and it will subside. And I thought that was very, very interesting. And he said, don't try and be a wave. It will crest and crash. And I looked at him, and as only President Clinton can do, looking you right in the eye, I said, President Clinton, then what should I be? And he didn't miss a beat, and he said to me, be a ripple. A ripple keeps reaching out. And I've hijacked that from President Clinton. I give him credit for that. But I realize that all of you are the ripple. And it's my ripple that I've been able to be blessed with, to have all of you here and to keep passing it on. So with that, I'd like to thank you again for attending. It's been certainly one of my greatest honors to be here in Bahrain, which is where it all started. And I hope and expect it will all continue for the next decades to come. So thank you all very much. And again, inshallah.
So it's my great honor now to welcome Lieutenant General Sheikh Mohammed bin Abdulla Al Khalifa, the chairperson of the Supreme Health Council, to give his opening speech. Please.
بسم الله الرحمن الرحيم. دكتورة جليلة السيد, Mr. George, Your Excellency, distinguished speakers, attendees from around the world, welcome to Bahrain and the C3 Summit, 2 days health dialogue on the evolution global healthcare between the United States of America and the Middle East. I thank His Majesty King Hamad bin Isa Al Khalifa and the Crown Prince and Prime Minister Prince Salman bin Hamad Al Khalifa for their unwavering support to the development of the Kingdom of Bahrain, especially in the healthcare arena. I thank the C3 for bestowing the lifetime achievement and to His Majesty the King Hamad bin Isa Al Khalifa in 2016 and the leadership award to His Royal Highness the Crown Prince Sheikh Salman bin Hamad Al Khalifa on his leadership successfully managing the COVID pandemic in Bahrain in 2021. C3 stands for the commerce, collaboration, and that impact our communities. Bahrain has had a long history of welcoming and trades over the hundreds of years, and the first United States missionaries set up the first modern hospital in the region in 1903, which has known to be what the American Mission Hospital is today. Bahrain's healthcare has evolved and grown through 2 pandemics to a modern healthcare ecosystem of public health, primary, secondary, and tertiary care through the public and private healthcare system. Globally, we face many challenges in the building of the healthcare system that are equitable and accessible for all with escalating costs and shortage of health care workers. There has been a steady shift of health care to caring for health and well-being in the domain of physical, mental, and spiritual health. Patient safety and quality are the benchmark by which health systems are benchmarked. We stand at the threshold of a major disruption of how care is both delivered and financed through all technology, through artificial intelligence technology and value-based reimbursement models. Climate changes will have significant impact on health as we witness around the world. Over the course of the next 2 days, these challenges and solutions will be discussed. Bahrain is open to collaborative partnership and investment in enhancing the quality of delivery. I thank the organizers of C3 in bringing the conference to Bahrain and wish all the participants over successful conference, and thank you very much.
I kindly invite His Excellency, the Minister of Health, to join us on the stage.
Please, for the people in the front seats, ladies and gentlemen, for a group photo. Please, if you can come on the stage. Yes, please, you know. So we'll start with our opening keynote plenary with the title of Building Today's Global Healthcare System, Deploying Tomorrow's Technology. And please welcome with me, we have Dr. Man Faris, who's the chairman for Global Patient Services from Cleveland Clinic from United States, and Dr. Toby Cosgrove he's the executive advisor and former CEO and president from Cleveland Clinic from United States. Please.
Well, good morning, everyone. It is actually a distinct honor to come to the Kingdom of Bahrain for the first time, and it's really a double honor to follow Sheikh Mohammed bin Abdullah Al Khalifa in his introductory remarks, and having the honor of a lifetime to introduce Toby Cosgrove, who has been my mentor and a role model for many years at the Cleveland Clinic. So my role today is simply to introduce Toby. And Toby had an illustrious career as a cardiac surgeon and as an innovator, as a researcher, and as a mentor to many. So he started his journey at Williams College, where he played basketball, and from there he had a knack for sailing. He went to Virginia Medical School, and from there he went to Mass General Hospital, where he started his career as a cardiac surgeon. Toby enlisted in the Air Force. He served in the Vietnam War. He had a bronze medal for his services. And then he was recruited to the Cleveland Clinic, where he performed 22,000 cardiac surgeries. Now, you might think that he was simply gifted. Toby, actually, there are some legendary stories about him spending nights perfecting his ability to work on the mitral valve in the anatomy lab at the Cleveland Clinic. If he was just simply following his gift, he would probably be an NBA player, but no, he decided to continue with his cardiac surgery career. At Cleveland Clinic, he also found time to have 30 patents for the mitral valve and beyond that are continued to be used around the world by cardiac surgeons today. From there, he served as CEO of the Cleveland Clinic between the years of 2004 and 2017. That's where you probably think the controversy started. On his first day at the Cleveland Clinic, he launched the slogan, "Patients First." This is an organization that is physician-led, but he really redefined healthcare by saying it is about patients. And today that model is also followed around many places and many major institutions. He fought against smoking, and he prohibited smoking everywhere in our campuses. He took against some major industries in fast food businesses, and he banned sugary drinks as well as fried food on campus. This was a tough battle that was written about in the Wall Street journals and the likes. Toby grew Cleveland Clinic to become a truly international healthcare organization. So he had the vision to go to Abu Dhabi and help build a hospital there. And then he also did see the vision of starting a healthcare system in London. So today we are, as a Cleveland Clinic, we do exist in London. And if any of you has had any chance to visit our hospital in London lately, you will be, I hope, impressed. Perhaps one of his most notable parts of his history is he's been an advisor to several U.S. presidents. As I will put in a plug for our afternoon session, we'll be talking about many things in his career, including the fact that he was invited to become Secretary of Veterans Affairs at some point. We can talk about many things, but there are a lot of things such as being the chair of or the president of the American Thoracic Society, as well as a member of the Academy of Medicine. But those are things we can look up online. So without further ado, Toby.
Good morning, Excellencies, ladies and gentlemen. It's a great pleasure to be here and be able to address you today and talk about what I think is a crisis in healthcare. I probably should stop right now after that introduction and take a bow and leave, but I'm going to press on anyhow. So I think that we are now facing a major crisis in healthcare. And I will point that out for really three reasons. First, the financial reasons. Secondly, for the lack of a workforce. And thirdly, because of the explosion in knowledge. And let me delve into each one of those a little bit more. Yeah, the GDP, the percentage of the GDP in the United States has continued to increase, and it's expected to be 20% of the GDP in the United States by 2030. This is an unsustainable increase in healthcare costs over time, and we have also been affected by inflation. If you look at the inflation that you see here, increasing costs in the pharmaceuticals and going up to 13%. Similarly, supplies have had an enormous increase in the cost, and this has been difficult for hospitals. If you look at the financial situation of hospitals in the United States, in the blue line, it looks at the median of the revenues. But more importantly, look at the yellow bars. The margins for hospitals in the United States has continually decreased. So last year, the margin for the Cleveland Clinic was 0.4%. It is estimated that you need a margin of 3.5% in order to be financially viable. These changes have had major influences across hospitals in the United States. There are currently 460 hospitals in the United States that are financially at risk of failure. 50% of those are rural hospitals in the United States, but this is a major issue that is affecting hospitals across our entire country. Similarly, there is a tremendous problem with our workforce. If you look at the shortage of nurses, it's projected to be over 400,000 nurse shortages. Similarly, there is a huge shortage of primary care physicians, leaving some 83 million people in the United States without a primary care physician. I can see my microphone got tired of me speaking. And similarly, this has resulted in almost 2 million shortages of healthcare workers in the United States across this time. And if you look at and project this across the world, it's projected that we're going to have almost 10 million shortages of healthcare workers across the world in the very near future. And subsequently, if you look at the explosion in knowledge that is happening right now, it is an enormous issue. That 1/3 of all the data in the world is healthcare related. Now, this is, and if you look at what a hospital generates, the average hospital generates twice as much data as in the Library of Congress on an annual basis. How are we going to deal with all this data? Imagine what this does to the average physician. There are currently 20,000 drugs approved by the FDA. There are 130,000 medical researchers who turn out 1.8 million medical articles annually in 30,000 journals. Additionally, we have to deal with genomics and the clinical trials. Nobody can possibly keep up with this. So how are we going to deal with this onslaught of data? And interesting, data in 1913 doubled every 150 years. It is now doubling every 73 days. No one can possibly manage this explosion in knowledge that we have to deal with, and it's going to take a new thinking. So and as a result, from something being a proven technology, either a medicine or a diagnostic procedure, until it becomes standard of care, it is 13 years. That's essentially the half-life of a doctor. And so what this is saying to us, if you don't learn it in your residency or in medical school, you're probably not going to practice it. So half of the doctors are not up to speed with what they're practicing, and we need to figure out how we're going to manage this explosion of data. Winston Churchill said that never waste a great crisis. And I think we have a crisis now in healthcare from a financial standpoint, from a labor force, and from the explosion in data that we need to begin to deal with. Michael Porter, who was referred to earlier, at the Harvard Business School, probably one of the most famous business professors in the world, said innovation is the only long-term solution to high-quality, affordable health care. By the way, Michael Porter was the person who coined the phrase value-based health care. So let's look at what the potential solutions to this are. And I would tell you right off the bat that I think that the solution to this is embracing AI and generative and LLMs. If you look at hospital expenses, they are 60% of running the hospital are salaries and benefits. And this hasn't changed over the years. And we continue to see an inflation in the cost of health care. There are essentially 500,000 hospital administrators in the United States. This has increased in the last 50 years 3,000%. Now, if you look at this, David Cutler, who's an economist at Harvard, said that he projected that you can take $1 trillion out of the cost of healthcare. That's out of $4.5 trillion in cost by improving the administrative functions and decreasing the number of personnel that are required. Essentially, what we need to do is substitute for labor technology. Now, if you look at the operative, and let me just give you a few examples of what have been employed recently to make my point about the opportunity to substitute technology for labor and personnel. Using Palantir, and for those of you who don't know, Palantir is the organization that put together the CIA, the FBI, and the security in the United States and coordinated them. And they have been working with the Cleveland Clinic for a number of years. And they have increased operating room utilization from 78% to 90%. Similarly, they reduce nurse manager work by 2 hours a day. Working with a company called Akasa, they have been able to replace and automate the billing that goes on in hospitals and increase productivity and the quality of the billing process. Similarly, look at how physicians are currently employed. They do 2 hours of every day in working with the electronic medical record and subsequently have to do 2 hours of pajama time or work subsequently later to take care of the electronic medical record. And across the Cleveland Clinic, there are 136 million emails coming in on a daily basis. How are physicians going to deal with this? And this also is some 15 inbox emails coming for each physician on a daily basis. So this is also, I might point out, this is how patients view their interactions with doctors.
Honey, look. He's playing doctor.
Yeah, that's doctor, all right.
That's how patients feel when a doctor sits and types during their interaction. And so ambient listening has now become available. So the conversation between a doctor and a patient can then be summarized at the end without the physician having to sit there and type all day long. And these are the automated clinical documentations that are now available for several different countries. Nuance, Abridge, Ambiance, and Suki all have got this capabilities. And I think this is going to become not a nice to have, but a have to have aspect of healthcare, particularly for primary care physicians and ultimately through the entire organization. So the physician inbox has got, as I said, 15 inbox messages a day that must be answered. Epic is arranged so 60% of those can be automated and reduce physician time. This is I want to talk to you about the bio button, which is just another example of how you can begin to automate the work. This particularly reduces the work of nurses. And I'll show you a quick video. Hopefully with sound.
A wearable button right on their
Let
chest.
me see that, the bio button.
The bio
right?
button,
the
yes.
Bio button.
So it's collecting vital signs at the minute level and flowing all that data into monitoring
on
software.
here.
Exactly, you just put it on like a sticker.
Like it.
And that's allowing the teams to watch every patient in every floor across our 8 hospitals
So
to be able
every
to.
patient ultimately that comes to the
Yes.
hospital is going to have this on.
That is what we're moving towards. We have 12 units up, and we're rolling out as fast as we can because we can see the power of this level of insight. So where we can take tasks off of the bedside or the care team and do that virtually and still have it be a great experience for the patient and the provider teams.
So this not only gives you, reduces the work of a nurse. You think of what it means to a patient not having to be awakened in the middle of the night to get their pulse, respiratory rate, and blood pressure taken. Think what it means instead of having vital signs every 4 hours to get vital signs on a minute-by-minute basis. This is 1,400 vital signs per 24 hours going directly into the electronic medical record. It reduces work, it improves the quality of care for patients, and it's ultimately going to save lives by predicting where you can begin, where the patient starts to have deterioration. So, and patient care and quality of care is also improved. Using Bayesian, a system which predicts whether someone is going to become septic or not, has increased the recognition of the incidence of sepsis by 39%. Using Health Data Analytics Institute, the Cleveland Clinic has been able to improve the prediction of surgical risk across the entire group of patients. Now, let me also point out one very important thing, and that is generative AI and how it is going to affect patients. This is not something that is currently there, but I think you can see from this data that it will be shortly. The USMLE is the most difficult medical exam in the world. When chat first came out, ChatGPT 3.5 got 60% of those questions on that exam correct. That's good enough to pass that exam. A year and a half later, ChatGPT 4.0 got 89% of those correct. And I think that this just shows that we are going to expect to see increasing quality of our chat and all the subsequent groups that are doing these ambient opportunities to manage the data. So as I see that, this is the opportunity to manage the vast amount of data that is now coming directly to physicians. It also is going to be able to in the future, manage patients in areas where they don't have physicians. It's also going to improve the quality of care and keep people up to date. It should shorten that period from proven to standard of care substantially, and it should improve the quality of care. I think it is going to be a mandate for us to embrace artificial intelligence and LM. So let me just say 2 other things. This is the prediction from Eric Schmidt, the former CEO of Google. It will enable breakthroughs in medicine and help solve the world's most pressing problems. Now the issue is, I think frankly, for all of us who are leaders in healthcare, this is not going to be something that is going to bubble up from the bottom. This is going to require leadership. We now have the vision of where healthcare can go, but the vision has got to have result in reality. And this is going to be dependent upon the leadership across healthcare and across the world. I think this is a challenge for all of us, but I think it's also the opportunity to deal with the enormous crisis that we have from the things that I've mentioned. Bring better healthcare, bring more efficient healthcare, reduce that improves the quality, and to reduce the cost of healthcare going forward. Thank you very much for the opportunity to talk with you today. It's been a distinct pleasure to be here.
Thank you so much for this brilliant presentation, and you probably just put it really nice way, how we have and how are the challenges that we are facing in the health system currently, and the role probably of IT, AI in the whole system, and how we can evolve into the future. Thank you so much. So we'll move to the next plenary session, and with the title of A New Paradigm for Health and Healthcare for Bahrain. And so with my great pleasure and honor to introduce Dr. George Cheriyan, who's the corporate CEO and the Chief Medical Officer from American Mission Hospital, who will moderate the session. And our really panelists will come, Dr. Mariam Al-Jalahma, who's the CEO of the government hospital, Dr. Ijlal Faisal Al-Alawi, who's the CEO of the primary care in Bahrain, and welcome Dr. Samia Bahram, who is the Associate Undersecretary for Public Health in the Ministry of Health, and Professor Samir Outoum, who is the President of RCSI in the Kingdom of Bahrain. So please all welcome on the stage.
Good morning. It gives me great pleasure to moderate this session because I'm amidst colleagues and friends. And so there are no formalities here, so I'm just going to address you by first name, doctor. So with that, let me just give you a brief of this. What is this paradigm shift that we're talking about in healthcare? Traditionally, all healthcare systems started with building of a hospital. And you saw the video at the beginning of the program where 120 years ago, a hospital was built in Bahrain. And that was the start of a healthcare system that evolved out of a hospital. And this has been the traditional model of building healthcare systems that started with a hospital, and then it sort of evolved outward, and primary care health centers were built right in the end. It should be the opposite way around. But this is how traditionally healthcare systems were built over the last 100 years. And so when I talk about a paradigm shift is, how do we begin to sort of translocate our thinking from having an existing healthcare system to a system that has to be reset so that the healthcare needs of tomorrow can actually be fulfilled. And that's a challenge for every healthcare system. And the Bahrain panel will address the challenges that we face here in the Kingdom of Bahrain. And for those of you who are not from Bahrain, we have the tremendous advantage of being an island. We are an island nation with a population of about 1.6 million people. And we already have a robust primary healthcare system, a secondary healthcare system, and a tertiary level healthcare system. But this system that we currently have might not be suitable for tomorrow's healthcare needs, as we just heard Toby talk about, what's going to happen in the future of healthcare. So I'm going to start off by asking you, Dr. Mariam, the first question. Bahrain managed the COVID pandemic exceedingly well. In fact, I think we came up in the top 3 countries that managed COVID. And normally what happens is, it is the resilience of healthcare systems that actually stand out when the systems are stressed. So when we were stressed with COVID, Bahrain did something remarkable. And you were part of that team, and I just want you to tell us how we manage that system.
Yes, thank you, Dr. George, and please allow me first to congratulate you for arranging and hosting such an important summit. I would say with confidence that Bahrain was successful because of the leadership and the teamwork. As you know, like anywhere else in the world, when there is a pandemic, then ministries of health would be held responsible to manage such event. This time in Bahrain, the case was different. From the beginning, His Royal Highness, the Crown Prince, Prime Minister, realized that this is not such a simple pandemic that Ministry of Health should manage alone. And it was managed like it's an enemy of the whole state. The whole state should deal with it. So the National Task Force for Combating COVID, chaired by His Excellency Sheikh Mohammed bin Abdullah, the President of the Supreme Council of Health, and his deputy as a Minister of Health, Dr. Jameela, with members from all other ministries. We worked as a team, harmonizing, communicating with everybody. The Ministry of Defense was there, Ministry of Interior Affairs, municipalities, Ministries of Health, Ministry of Trade. All the ministries worked as one team, regardless of what's your position. The second thing we did was something that at the beginning we were saying, do we really need that? But it was a very important thing, establishing what we called the war room, which was a very important operating place to manage the whole communication, where data were collected, statistics were generated, incidents reported, patients were managed. And this was a very important step. That because if you, the most important thing in a crisis is to communicate, to have a bigger network. Immediately, the pandemic was managed through developing quarantine places, military established a field hospital, a field ICU, everybody worked. And also, one of the most important things that was involving the private sector from the beginning. Private sector had a very important role, not only for managing even quarantine, isolation, but also they supported the government sector where they were cases of long stay patients and like normal deliveries were shifted to the private sector, so the government hospitals can manage the admission of cases at that time. And not only this, but the whole government, whatever diagnostic needed, medication needed, medical supplies needed, everybody worked together and everything was there to our support. The Prime Minister Office staff were all dedicated with us to communicate and support us. So the secret of this is when the whole nation managed this pandemic as one body, as one team, with a visionary leadership, this was the success story.
I think the greatest success story was the data. The data was
the
available,
data, yes, as I said,
all
because
the
of the war room,
yeah,
yes.
and all of the decisions were actually taken through
based on
data, which
yes.
was it. Dr. Mary, you are here wearing two hats, because you are now the CEO of all the government hospitals, but until very recently, you were the CEO of the regulatory bodies that oversaw the licensing of physicians, licensing of facilities, and so on and so forth. So this question is regarding the regulatory framework. Now, how do you foresee regulation being a help or a hindrance in tomorrow's fast-changing healthcare world? Because what was okay now and was in the past is going to be very different. You know, with genomics, precision medicine, AI, generative AI, there are so many new things that's going to shift the paradigm outside our well-known box. So how are we going to cope with the regulatory changes? Even though I can ask you that question because you were in this role for a number of years.
Thank you very much. Yes, again, Bahrain is unique in regulating the health sector, where only one regulatory body is regulating the healthcare facilities, the professionals, the medication, medical devices, even investigating medical errors. So it's all under one roof. As an investor, you have to deal with one body. As a physician, you have to deal with one body. As a company managing or supplies and so on. So this is very good in terms of going to multiple bodies to process your request. The regulatory body before and during the crisis role was very important. Now, regulations have to be flexible. They have to change accordingly. For example, let me give you an example. Before the crisis, there were no regulation for telemedicine in Bahrain. And we were able to do it and gave licensing to companies to run telemedicines. And this was implemented immediately when the crisis was there for the pandemic. We were ready. Also, facilitating regulation of medical supplies and medication as well, utilizing what we call reliance with other authorities. Like if, for example, if a medicine is approved by FDA, then it has a fast track. We have a new resolution issued by the Supreme Council of Health stating that we have 5 authorities. If these have approved a medication, then they have definitely fast track to enter Bahrain. And so on, when you look at in terms of artificial intelligence, implementing it in surgeries and in communication, the regulatory body has to be flexible, updated, change with time, and I think reliance is very important to fasten the process.
Dr. Angela, now coming to you in terms of the primary care domain, 95% of our patients, their requirements rest within the primary care domain. And yet, how do you seamlessly integrate the primary care to the future of tertiary care or genomic medicine? But yet, today, primary care, secondary care, tertiary care are siloed. They don't talk to each other, or they talk to each other, but they don't talk to each other very well. But in the future, healthcare data is shared across these domains. And how do you see within the primary care domain how this patient data and patient care would actually flow back and forth between the primary care to, let's say, the hospital sector?
Yeah. Thank you, Dr. Cheriyan, and thank you for inviting me to take part of this panel. Actually, in Bahrain, and as you mentioned, we have a robust health system which already had an established good communication between all levels of health sectors, including primary care, secondary care, and tertiary care. And this also includes governmental hospital as well as private hospitals as well. Coordination is ongoing, established guidelines of communication, referral guidelines between all healthcare levels is already there and being supervised by the Supreme Council of Health. The upcoming, since the issuance of the health insurance law in Bahrain 2018, work has been done to unify the electronic medical records between all health sectors, including private and governmental, which will eventually strengthen this relation between all levels of health sectors. In addition, because of exchange of training and expertise between all levels of health sector, for example, we have strong communication and exchange of expertise with Salman Medical Hospital, King Hamad Hospital, BDF Hospital, and American Mission, among other hospitals as well. Training is ongoing to keep our staff updated with the evolving of the health center, health needs all over the world, and to keep them providing the quality health service that we always aim for.
Good. today in Bahrain, 65% of the healthcare domain rests with the public, between Dr. Miriam and you. You're the two people responsible for 65% of the healthcare. I'm on the private side. So how do you see this public-private partnership coming together so that we can, in the future, redefine the care that our patients expect us to provide, whether it is in the public sector or the private sector? Because I know with the social insurance being implemented, the patients have a choice to either receive the care in the public sector or the private sector. So how do you see that evolve, this public-private partnership?
Actually, the private sectors play a very important role in Bahrain in delivering the health services. They are strategic partners. The private sector is being represented in the Supreme Council of Health, as well as all the main health committees, such as communicable, non-communicable, anti-smoking, One Health, and other national health committees. This which strengthen the public-private partnership. We also look into private sector as a model for the upcoming health insurance, because usually private sector is based on the on providing high quality healthcare while also ensuring financial stability, which is the base of the value-based healthcare system we are aiming for. Also, I believe private sector can play a great role in conducting training and research, which will give us more data to be analyzed. The health information system will have data analysis tool, will track performance both in private sector and also in government sector, which will also enhance the patient outcome and provide the quality of care we are aiming for. So I see a great opportunity in private-public partnership.
I just need to comment on one thing. I think we have seen our prominent speaker at the beginning talking about the crisis that the healthcare sector is facing. And looking at all the elements he presented, governments cannot continue working alone. Expenses are rising. Even the expenses of health in the government sector is much higher than the private sector. Looking at, I don't want to discuss why it's more, but we have many elements that make it more expensive. So I think the move now is to work together with the private sector to take some of their responsibilities and maybe make the share, as you said, 65 or 60-40, to make it equal, or reverse it at least. Yeah. Thank you.
Dr. Sabir, you know, you are in the public health domain, and we have been reasonably successful in how we manage the COVID pandemic. But as we all know, the next pandemic might be just around the corner. So how do you see, you're a primary care physician with years of experience in primary care. So in the public health role, how do you see how resilient is the Bahrain healthcare system in facing another pandemic, whatever it is?
Thank you, Mr. Cheriyan, for this question. I think all of us will agree that COVID-19, it was a global event, and all of us will learn so many lessons out of that pandemic. And we in Bahrain, we took our preparedness to another level on different aspects, starting from the infrastructure. So we in Bahrain looked into that, because all the governments, they realized that we have to invest into the healthcare systems. So looking at the infrastructure, we started to look into building more healthcare services, whether it is at the level of governmental or private sector, improving the ICU units, expanding the ICU units, increasing the level of lab capacity, training our people at the level of public health directorate or other health sectors. Not only investing into the infrastructure, even improving our surveillance and early detection. As you noticed, I mean, all of us, we agree that how important it was to know what's going on in the other countries. So we do have a preparedness and response team, and this team they are well trained and they have gone through so many training sessions in order to be ready in case, la samhallah, if there is any kind of another outbreak. And this team, they have conducted simulating exercises with the governmental sector and non-governmental sector, just to see how we are ready in case if there is another outbreak. So moving from infrastructure to the surveillance, and we have improved our communication, as Dr. Mariam mentioned earlier, the communication. All of us, we realized how important it was to have Be Aware application. And this application was there to, it was a sort of communication between us as healthcare workers as well as with the community. You cannot keep your community away from you. So we improved our communication with the community, and not only just the community at the level of Bahrain. We do have better communication now if you're talking to the Gulf CDC or globally as well. So moving from infrastructure to the surveillance to the communication, we looked into how fast it was to have the COVID vaccine. The whole process was accelerated. So we got the benefit of that, even to have, is there any problem with our supply chain? How can we improve it? How can we improve things and to get them as soon as possible when there is any kind of outbreak? This all we learned it from during the COVID. The other thing is to share our data. Yeah. Sharing data, it was really important, and now we did realize that how important to share the data, whether at the level of Bahrain or GCC or globally. And there was an article which was published in July 2022 about Bahrain, the case, showcase of Bahrain, how did we deal with COVID, and we shared our data internationally.
Thank you. Professor Sabir too. You are the president of the Royal College of Surgeons in an illustrious college that has got a 300-year history, and the RCSI has now been in Bahrain for over 20 years, and you're heading a very prestigious academic medical institution training undergraduates. Now, from our experience thus far and looking into the future of healthcare, how do you see the evolution of training of healthcare workers? Because we just heard Toby talk about the great shortage of the big workforce. How do you see the training of the future of workforce evolve in Bahrain?
First of all, thank you very much, and congratulations on organizing this very important meeting. This is a very important question, and I think the importance of it is the managing of healthcare challenges in the future, certainly linked to what we teach in our medical school for our undergraduate students. And it's a big subject, and I'm sure there will be a lot of time required for that. But briefly and generally, I would like to perhaps share with you some of the experience we had recently in Royal College of Surgeons, because we have reviewed our medical curriculum recently. And the methodology is basically we used sort of a holistic, transformative framework, which depends on key drivers. The key drivers are the brain, the mind, the heart, and the hands, and I'll explain what does that mean. So under the brain, for instance, which is mainly the knowledge and the technology. Our technology, I'll come back perhaps to the end about the technology, but for information and for knowledge, it's important that we change our tactic and approach in terms of what knowledge we provide to the undergraduates. We want critical thinkers. We want long life learners. We want graduates who have a lot of soft skills, which they can be used to earn the knowledge. So I think that's in general is very important under the brain. But I go to the mind part of it. And the mind part, which basically involves leadership and teamwork. Now, in standard classical medical programs, perhaps the one you and I have in the past, there will be focus a lot on knowledge, skills, and attitude. Yes. And if you look at the graduate profile of all medical schools at that time, these are the three pillars they will look at, because the objective is to graduate somebody who deal with patients, who treat patients. Now, in this era, the scope of the physician is not only to manage patients. Now, in a system of healthcare, we talk about transformative here. There is a continuous dynamic transformation of the healthcare system. Those physicians needs to have a role in that, and sometimes a leadership role on this transformation. So teaching leadership skills is very important and has now been added. The other point I think worth mentioning is graduates have to understand how to work within a team, because it is the teamwork. And it's not only communicating between each other during the team, but to understand the role of each health worker in providing the health care and the patient management. And that's very crucial to that. Then we go to the heart, which is the values, and the values, under that will be the compassion and the sympathy, and we need to continue definitely teaching that. And then, of course, the hands, where the skills, which we need to teach the skills and how to be a safe doctor. But just before I close, go back to the technology, because I think that's a very, very important subject. I mean, technology by and large is overwhelming. And transformation of medical education or the healthcare delivery is already requires technology. So technology is already incorporated there. So just briefly on the medical education side, there's a lot of technology modalities which we have now. There's no time to mention them, but certainly they need to be adopted in our system. Now, we mentioned about COVID. There's a lot of lessons we have learned from COVID, and we need to incorporate that in our evolving curriculum. There is a lot of digital resources now, and I think there will be always a question I always raise with my colleagues is how much information we need to provide, the volume of the information we need to provide to the undergraduate students. Do we need to utilize all their memory with information they can easily now access on their iPhone or on the internet? Now, do we need them to memorize Krebs cycle, or they just go to the internet and they get the information about Krebs cycle? I think that's very important. Now, it's now I think a direction we need to review and see, are we still need in a lecture on arrhythmias of the heart to give 100 slide, or that's no need. That's one aspect, I think, of the technology we need to. Now, when it comes to the healthcare service, we need to prepare the graduates how to deal with this technology when they provide. And I think mentioned today about, electronic, records. That's very important, and we are very pleased and happy that in Bahrain, most of our hospitals here, they use electronic records. So that's important for the students to learn. And when it comes to artificial intelligence, I mean, it could be a point when it comes to medical education of debate, actually. I mean, I know some medical schools, they have barred the technology from their students simply because they think it will provide a lot of information and that will ease, assignments and so on. But I don't agree, of course, with that, because our policy as RCSI when it comes with artificial intelligence are two things. One is we have to understand how we deal with this technology, how we can utilize it positively to improve student experience and student learning. And part of that is the IT element, which was mentioned today. And that's something new, basically, to teach an undergraduate medical education some IT skills. Because artificial intelligence, at the end of the day, it's all about data and data collecting. And the AI we use is mainly using data from other countries. And when it comes, I think, to diseases, as we know, there is some variation, depends on ethnicity, depends on genes, and so on. So we need to collect our own data. And that's the part, I think, of innovation, which is the second part of the policy, is how the students can utilize what they have in order to use it for their developments. But at the same time, not forgetting the heart, which is the value, is I don't agree that technology and artificial intelligence that will replace the role of the physicians completely. I mean, you can debate about that, but I think the patient-physician interaction is still very important. The human touch is very important, and I think that's where a recent study by the British Medical Association, they went to the public, they went to the malls and asked people, who is the best doctor in your opinion? And 95% of the answers is the doctor who cares, the doctors who listens, doctors who show empathy, and so on. So we still need to ensure that that's the expectation of the patients, and we don't lose it.
Jack Welch mentioned there are only three things that you need to know when you run a company. One is customer experience and feedback. Number two, patient engagement or your staff engagement. And number three is cash flow. These are the only three things you need to worry about if you want to run a successful company. Now in healthcare, the only three things that matters in the future of health is, as far as the patient is concerned, cost, convenience, and connectivity. Yes. Cost, convenience, and connectivity. If we could create healthcare systems that would be cost effective, that would be connected to the patients at all times, and is convenient for the patients, trust me, most healthcare systems will shift their paradigms overnight. But unfortunately, as simple as this sounds, it is very, very difficult in how you try to reframe and reconstruct systems. Professor Rotum, I want to ask you one more question before we finish this session, is that what are the challenges, particularly in Bahrain, of those undergraduates who come out from the RCSI for the Arabian Gulf University when it comes to postgraduate training?
Sure. Again, that's another important question. Just to give it some perspective, perhaps, to this question is, I think it was mentioned today about the global need for workforce, and I think GCC is not different from the world. Despite there is an increase in the health care workers, the national, I'm talking about the national here, just GCC in general. I mean, I think Bahrain is part of GCC, so that's applicable to it as well. There is still a shortage of skilled workers, and especially when it comes to higher specialty and some subspecialties on that. I think one other aspect which really worth mentioning here is there are some change in the demography here. I mean, I think also it was mentioned this morning, the life expectancy has improved, the infant mortality rate has been improved, and so the population growth basically has improved, and I think GCC will be one of the highest countries in the world when it comes to population growth. And there is another factor involved here is the immigrant workers, which is also in GCC. I mean, some of the countries of GCC, they have immigrant workers up to 50% of their national composition.
70%.
Which is, yes, which is absolutely very huge. So I think one of the response to that is medical schools increase in numbers. So I think the latest statistic I have, I'm not sure it's still accurate, is in 2020, GCC have about 139 medical schools. I'm sure the number has increased now. And then they begin to introduce the undergraduates. The issue with having or piling up undergraduates at the level of GPs. GPs means somebody who just graduated with an internship. I'm not referring to, because sometimes you refer to a family physician. So these GPs, they have a reality is local limitations in terms of finding postgraduate training. We don't want to keep them at the level of GPs because medicine is complex, medicine requires specializations, and they have to find their way on that. So the alternative for them is to look for some opportunities international. And if I just briefly speak about US, for instance, I mean, which is a very common destination for graduates to go for postgraduate training, things have changed. I mean, in the last 5 to 7 years, the medical schools in US have increased, which indicates that the posts for international medical graduates, the IMGs, have also increased. And the figure is about 20–25%, which is very, very significant if you consider the big number we have of graduates going to the US. And it's not only the numbers have decreased, but also the restriction on specialties. So the non-procedurals, if you like, or what we call dry subjects, are basically available for the IMGs, but not the others. And you add on that also is the competition now is becoming very, very important. In the past, I mean, your time, my time, we were doing USMLE or ACFM exams, and a lot of the matching of the graduates will be based on the scores. But now that things have completely changed. Even USMLE Part 1 now is a pass-fail. They don't have scores. So basically, they look at portfolio. They would like the graduates expect to do some research, some publications. They have to do some electives, let's say in North America. They expect volunteering and so on. So basically, it's becoming very, very competitive. So there's now a new approach, and by some of the top actually universities and hospitals in the US, is they begin to produce programs they call out of the match. And out of the match simply is they provide you programs, postgraduate program, but you have to pay for it. And now going back to the cost. And if you add the cost for all these programs together, certainly they add up a lot. And that, I think, is important to consider.
Professor, we have an audience here of the most elite medical schools represented here, from Cleveland Clinic to Mayo to the Brigham. Yes. All of the elite med schools from the US are based here. So maybe our pitch should be to them to see how these barriers or obstacles to sort of allow free flow of yes. postgraduate training research to become easier rather than difficult. And I think I don't know whether I've overrun with time, Jameela. Yeah, I'm good with time. So I just want to now open up this panel to a couple of questions from the audience. And so if you want to ask a question, please raise your hand. We will get a mic to you. Just briefly say who you are and from which institution, and you can shoot the question to the panel up here. So any questions from the audience? Yeah. Dr. Brahma, you can stand up and they will give you the mic.
Good morning, the whole panel, for a wonderful discussion. My name is Dr. Brahmara. I head pediatrics in the American Mission Hospital. My question is with respect to patient safety and patient experience. if any of the private hospitals requires some, referral to the government, how can we make this seamless and how can we make this convenient for both the patient as well as the referring hospital? That is number one. And the second is there a system, can we come up with a system where when a particular hospital doesn't have a subspecialty, can there be a system, a seamless system where we get some help from the tertiary care center? All this is with respect to patient experience and patient safety. Thank you very much.
That question, I think I will give it directly to Dr. Miriam, who is the CEO of government hospitals. So it's a timely question, Dr. Miriam.
So for those who are not from Bahrain, Salman Medical Center is one of the major hospitals in the country with 1,200 beds and the largest ICU. And when everybody needs patients to move to secondary care, it's Salman Medical Center. Looking into that, even those patients who are in critical care in the private hospital, maybe they are not able to pay for the cost of ICU, then they demand to be shifted to the government hospital. So that's a big issue where we find it difficult between us and the private sector to accommodate such patients. But as you know, there's been a system where emergency doctors or ICU doctors or the consultant managing the case to call our team and arrange transfer of the patient accordingly. Now, there are some situations where we request the private sector to maintain the patient until we find a bed, for example, because we are facing this, especially with when the patient needs isolation or ICU. Now, we were able to reduce the pending admission in emergency, which reached 20 to 30 now to below 10, which is an extremely fast track where we increase the number of beds to utilize that. But definitely, I agree with you that we need to, through the Supreme Council of Health, to sit together and put a strategy for that, because as a government hospital, maybe we face also difficulty to receive all the patients, not because private sector is not able to manage them, because sometimes the patients don't want to continue and pay for this. Maybe when the social health insurance is implemented, the story will be different, but definitely we do need that. Thank you.
George, I have a quick question here.
Yep.
I have a quick question for the regulators. What we found lately with virtual health, that the biggest barrier is the regulation, that physicians are not licensed in different states in the United States or in different countries, and therefore they cannot offer services across those borders. How is the situation from the regulator standpoint in the GCC countries, and can we break those barriers so that there is free flow of information and services without erecting those barriers?
I would answer for the regulatory body because I was managing that. And definitely when we approved or licensed telemedicine facilities in Bahrain, we approved that any doctor from other country, as long as they are licensed in their own country, just provide us with a copy of the license and their CV, and we would consider them approved. And of course, the ethical responsibility as per the regulation lies within the virtual company who's providing such service. And if there is any medical error or any ethical error, then again, we cannot investigate the doctor who's living abroad, but we consider that we can communicate with the authority. But we do give license. We all register them through their license in their country.
One of the problems, Dr. Mann,
allow me, sorry for interruption. I just want to add that currently there is a proposal to establish a GCC virtual hospital proposed by the Kingdom of Bahrain. There is a team formulated by the GCC Council to monitor the implementation of such proposal, bearing in mind that this proposal will not go forward unless all doctors participating in it would be compliant with the licensing requirements in all GCC countries. And hopefully, after GCC see we can expand it to be covering countries from other parts of the world.
Dr. Samir, last question. We have
just a quick comment, I think, on the private government partnership, because I think that's really extremely important. And I'm just happy to announce that we are launching a program, an internship program in Bahrain. This came as a result of a partnership between the private sector that's represented by the American Mission Hospital and the government hospitals represented by Salmania Medical Complex. And I think that's a starting point of a postgraduate training, which we can use the same model for residency program in the future. I think it's an excellent program, benchmark against the Irish Medical Council, the GMC requirements, as well as the local requirements in NHRA. And I would like to extend my thanks and appreciation to the Health Supreme Council and to the Bahrain Specialist Board for basically approving that program, which hopefully will start in June, July this year.
Thank you, Professor Samir. That was a nice segue to finish our panel. Dr. Mariam, Dr. Ijlad, Dr. Samia, Professor Otum, thank you so much.
Thank you so much. Thank you for the excellent panel discussion that we have, and that reflects how the health system in Bahrain is being evolving, and we are looking forward for more achievements in our country. So it's now for the good news. This is the time for the coffee break, which we are waiting for. So you'll have 15 minutes for the coffee, and please, we'll be back by 10:50. So we'll give you a longer break for lunch and prayer time. Thank you so much. 10:50, we'll be back. Welcome back. I think it's time to start, so yeah, people are coming, so we can probably close the doors and start this next session. So the next session that we'll start right now at 11 o'clock is about rapid evolution of government policies and the role of regulatory and public-private partnership. And really, it's a real honor really to introduce the Ambassador Dr. Deborah Birx, who's been the White House Coronavirus Task Force from 2020-2021. So please join us on the stage. And we have in the panelists, we have Dr. Stephen Hahn, who's the CEO partner from Flagship Pioneering and Chief Executive Officer from Harbinger Health, and Mr. Tom Ardell, who is the Vice President of Head of International Health, Plantier Technologies from United States, and myself as a Senior Infectious Disease from King Hamad American Mission Hospital. So please, for the panelists on the stage.
Great, thank you, Jameela. All right, for those 10 people who returned from coffee break, thank you. Really grateful. We will have questions, so get your questions and start thinking about them right now. This panel was carefully selected to really represent my unsung heroes through the COVID pandemic. These are people who dropped everything, picked up the thread, worked together, and I think what was missing in a lot of the previous discussions is how much internationally we work together behind the scenes, and how are we going to really make sure that that happens. So I'm going to do my own little introduction so that everybody can understand how amazing these people are. Dr. Jameela was critical in the response, but you probably don't know that we were using the data from the Middle East for our own patients in the United States to understand the durability of the vaccines. So you had the data that we needed, and you can't wait for these things to be published. You have to get it in real time, and I really want to thank Bahrain. We got that information through your ambassador to the United States, who provided that information when I had a question. Steve Hahn was head of the FDA, which was the place that really pushed out all of the tests, all of the therapeutics, and the vaccines for COVID, all of that happening in the first 7 months, which is really quite extraordinary. And he really brought innovation, talk about changing regulatory pathways, quite extraordinary. And Tom is from Palantir, and I was so jealous of Bahrain and many of the other countries because they had, as you heard this morning, integrated data. So they could see patients in their patient journey from clinics to hospitals. In the US, we don't have integrated data. In fact, when I arrived at the White House, we had no data except case numbers out of states. And it was really Palantir who helped us pull together all of the data from every single testing site in the United States, which are often private laboratories. Those are our largest testers. Very little testing is done in our public hospitals or our public health. Pulled together all of the testing data, all of the number of individuals that were hospitalized and their outcomes, and then tracked all the vaccines and the vaccine delivery in real time. So within the first 3 weeks, we had data from across the country because of the private sector coming to help us. And I guess that's the last thing I want to say before I turn to ask really questions of the panel is, I heard that in your panel from Bahrain, people work together in new ways. Imagine if the public and private sector were working together every day in new ways to bring innovations to us in real time. As Toby talked about, you can't wait 13 years from the journal publication and FDA new drug licensure to actually becoming standard of care. And I think these lessons learned are really going to be critical. So I'm going to start with Jameela because you're going to present kind of a summary of what Bahrain did to really address the COVID pandemic and what we can learn.
Thank you so much. Thank you. And I think, I'll just present the outline. It's hard really to present the work that has been done by a great team, actually hundreds and thousands of people that are working as one team. And here in Bahrain, we call it Team Bahrain. So it is starting from the leadership to everybody who was working in the front line or even in the hospitals, primary care, in the borders. So all were there working together. So I'll just go over an outline and it probably show you some of the elements that we've discussed earlier in the morning and probably give you insight and probably for the steps forward. So these are the major points that I'll go through in my presentation. But as I said, it will be really quick just to make sure that you have the outline, and especially for the people who are coming from outside of Bahrain, just to have a flavor of how we really tackled the COVID-19 pandemic. So starting with number one, really, we could not, and I can say it, and all the members of the National Task Force of COVID-19 in Bahrain, we could not done what we did without the high support and the visionary of our leadership, His Majesty, King of Bahrain, and the Prime Minister, Crown Prince, that give us all the support and all the needed, really, help to be able to execute. And I think the key factor was early planning. And one fact about Bahrain planning, we started the planning in January 2020 before any case even reached Bahrain. So we put the plan for the highest number and calculation of what's the number of ICU bed Bahrain will need it if it was a pandemic. And this is before even WHO announced its pandemic. We got the budget for it, we got the plan, and even we were asking, and that was from His Royal Highness the Crown Prince, to have enough number of PCR when nobody was talking and knows what's PCR even. So that was how early we started in the Kingdom of Bahrain. The next step actually was early response and national task force. And I really will just point a couple of points. You hear something about the war room, and this was the command center for all of us. It's integrated system. The team, there were around 50 people working around the clock, 24/7, collecting all the information, not only cases, tracing, contact, testing, vaccination, and transform it in a dashboard which was presented to the National Task Force and the leader to make a decision. The task force team, we were meeting every day, 1, 2, 3, 4 hours, as long it takes to make a decision. We have aggressive testing. Probably Bahrain, if you know, we were the highest, the countries, on the top 10 countries that they have, highest number of tests per population. And that was not only for testing, to pick up the cases, treat early, and do a good tracing. The other thing was really have a multilingual media campaign. This was crucial before, now, and in the future. Media campaign was very important to increase the transparency level between us as even as a government body and between the population of Bahrain. So when we said you can take vaccine, believe me, the people trust us and they were taking the vaccine. When we said start booster, when nobody in the world started booster, they believe in us and they started the booster. So that was a major fact. The number of beds, Bahrain is a small country, as you see, it's 1.8, the population is 1.8 million. When we started, we didn't have more than 100 ICU beds. When we planned for 500 ICU beds, and we were able to do it, and we have a field hospitals done in 1 to 2 weeks where we started all the hospitals in Bahrain. Then we have also the integrated system, and this is where our local data were collected from everywhere and transformed, as we said, to dashboards. So this is the war room. Actually, it was run with the support of Prime Minister Office. We have representation of Ministry of Interior, Ministry of Health, all the healthcare facilities, converting all the information about COVID. I will not say every 24 hours, believe me, it was by the minute. It's midnight, early morning. If anybody from the war room here, they can say they were up, collecting data, making dashboard, representing it to the leader of the country. So that was really amazing for decision making. These are sample. This is not now number, not actual figure right now, but this is example how we will run it. By number of admission to the hospital, number to admission to the ICU. What's the mortality? In which facilities? In Bahrain, actually, we have COVID-19 facilities from isolation center to treatment only for mild cases, to moderate to severe cases and ICU. So it was better segregated to be able to utilize our resources. So we didn't mix and match all the cases in one center. we were really dividing them. So we're able to use this information for awareness campaign and also for the data collection. We were analyzing our data, and we did a lot of mitigation and actually containment. Testing and tracing was major. We have random testing, contact tracing testing. We have even mobile unit going to the people wherever they want to be tested. And our results were even in the peak of the pandemic, maximum 8 hours, and you get your result. No, nothing beyond that. So that was very important for us. Robust assessment and alert framework. This is a major. If you see in this slide, you see that we add something called the traffic light system. This is the highest level of transparency we have with the people of Bahrain, which means, and I'll go into the details, if the number of cases are higher, number of ICU occupancy is higher, we'll have to move in that traffic light to have probably some closure of the business or probably have education online. So that's the people know. If you move to orange, everybody knows at midnight, tomorrow is orange. You'll be staying at home. So people know what decision we'll be making. Then the public health intervention and national campaign. I will stress here, Bahrain is one of the few countries we didn't implement lockdown complete. We didn't do it. We were moving with public health intervention and the economic crisis. Bahrain has assigned big budget. This was $500 million for the economy, for the COVID-19, to be assigned for the people who were affected by the pandemic, even paying the salaries for the private sector if they cannot pay for their employee. We want to make sure that the social and economy level in Bahrain maintained during the pandemic. So this is testing, I said. We did a lot really in testing just to make sure to pick up the cases early, trace them, get them in the treatment facilities, and provide the best of care. This is the alert system, traffic system, and if you see it really, there was, we had a lot of parameters that we used to assess, but number one was for us is number of cases in the ICU. That was a major one for us. If it's higher, we have to switch and we have to do extra measure to control the pandemic. And this is where the parameter, probably, people still remember, we were following the number of new cases, cumulative growth, R-naughts, contact pair cases, bed occupancy, ICU admission, economic impact, and vaccine availability. And we were tracing this on a timely manner every day, every hour of the day. National vaccination campaign will not go into detail, but I really highlight a couple of important points. First of all, Bahrain, probably one of the few countries, we have 5 types of vaccine available. From Sinopharm to AstraZeneca when it was there, to Pfizer. So we had the freedom that anybody choose whatever vaccine you like. It's been approved by Nahra. At that time, Dr. Mariam Al-Jalahma was really the major point for quick approval for all these vaccination. And not only they have the freedom to ask for any vaccine they like, vaccination and treatment in Bahrain, whether you are a citizen or not, it's a free of charge all the way. And that was by his direction from His Majesty the King. It's a free of charge because it's a public health issue. And then we have the Be Aware system, which was online app, and we have it in our phone to know if I am positive. Even if I pass by somebody who's positive, it will ask me if I want to be tested. So this is how much it's integrated, and it has our vaccination. And really, we had a priority for high-risk group, so they can be prioritized without appointment. And even we went home for disabled people, elderly population, to give them vaccine at home if they cannot come to the vaccination center. So that's how the extent that we move on. This is example how we were following. And as I said, Bahrain probably one of the few countries that started booster dose based on our local data when there was no data internationally about giving booster. So public health intervention, we were discussing it when it start, to stop kids from going to school. What's the, shall we do one intervention or multiple intervention? When to start, when to stop it? The lag time between the new cases, the peak, and when it started. So we put all together to make sure that we did it right. So this is what the National Task Force has been addressing, all related to partial shutdown, stocks, PPEs. There was challenge all over the world. Thanks God, we never had any shortage of any PPE at any time. We had enough to run, and even we were donating to other countries. Research and treatment was a major. We really did several clinical trials and research within COVID, and we share it with the world, and we have a big media campaign. If you look across boards, everybody, and I think it was mentioned in the previous panel, each one in Bahrain played a role as a citizen, as a resident, and even in a position, from public health intervention to medical, to foreign affairs, security, economic, as we said, was a major, educational plan, social plan, even the environmental. We were discussing about the sewage, testing the sewage to see what's happening with the COVID-19, and we were where to go from there. Legislative body, probably this is the other hat I wear from the Shura Council. A lot has been passed in a timely manner to assign the budget for the people of Bahrain to have it run. People are comfortable. Even if you are at home, your salary was paid. House loan was stopped for 6 months and then extended. Payment was done. A lot of rent has been stopped, even especially for tourism institution, because we want to help the people to go through the pandemic without any impact on the social level that they were living. And finally, I think it was mentioned, we were really proud and really honored that WHO has been visiting all the countries in the Emro region, and they selected Bahrain as a case study because they found there are a lot of successful factors that make us as a case study, and this is the WHO wording. The experience for Bahrain was multi-sectorial cooperation, partnership and trust formed foundation to contact tracing, isolation, triaging, treatment and mitigation measure, awareness campaign, social media, economic strategies and package, and expansion of services and maintaining all the essential services. And this is their word. The word which resonated most loudly throughout Bahrain response is solidarity. It's reflected in each action, every decision made. It was not a whole of government approach, it was a whole of society approach, and this is very important. While the world thought that the initial COVID-19 would be a sprint, Bahrain prepared for a marathon. That's the WHO wording. The experience and lessons learned from Bahrain experience through testing, vaccination, and treatment can really go, and a lot of people probably can help for the future. So, finally, just lesson learned. I think we learned a lot. We cannot summarize it in one slide, but this is probably my view of seeing it. You have to be really prepared. And probably the question, are we ready for the next pandemic? I'm not sure yet, but probably we can discuss it. Health, research, education is priority. IT solution and innovation played a major role, and I think we should maintain utilizing it very well to be innovative, to be patient. Infectious disease really knows no border. So for the future, I think these, if we want to be ready for any pandemic or any problem, I think this is my opinion, is really crucial. Documentation and data, resilience of the health system. You have to be. Enhanced coordination, collaboration, investment in the health system, whether care worker or even infrastructure, surveillance and collection of data, risk communication and community engagement, good media campaign, transparency, and be aware that you have to be sustainable all over the period and take it for the future. So that's in summary, try to summarize a couple of slides, Bahrain experience. Thank you.
Great, well that was very comprehensive. Steve, turning to you, and I think the FDA is known in the United States for being very careful, very bureaucratic, very deliberative, yet in the pandemic, you had to go from testing only in public health institutions to testing everywhere in the United States. You had to develop and approve therapeutics, and you had to ensure that vaccines move forward. How did you do that? And how did you get an agency that was used to, let's say, walking to sprint at this speed?
Yeah, thanks, Deb. It's great to be here. Dr. Salman, tremendous work, and your conclusions at the end, I could not agree more, particularly around the communication and transparency, so important for building trust. So early on in the pandemic, I met Deb, obviously, and we worked together for 8 very long months, but good months. We started an emergency response management team. We decided from the beginning, it was late January, that we had to bring all the leadership together to have transparency and communication and to talk about what was going to face us. And that, I think, really helped us set the stage for an all-of-agency response. And you're right, we have seen the FDA in particular be somewhat cumbersome, bureaucratic, and slow. It takes entirely too long for products to be approved, no question about it. And before the pandemic, the quickest that a vaccine was ever started and then approved was 4 years. And during this time, of course, it was 11 months from the identification of the viral sequence on January 10th, 2020 to the first EUA on December 11th. It was 11 months, a pretty remarkable amount of time. And I think it was because we really had no choice. The FDA is, like most regulatory agencies, is the pragmatic group that assesses the risk and benefit in the translation from innovation to commercialization. And we use the emergency use authorization process to help us expedite and to work very closely with industry. And I think that's a lesson that we learned. Unfortunately, I think we've slipped a little back in healthcare, what we call drift, where we've gone back to the old way of doing things. But this engagement with industry, not giving industry a free pass, but this engagement with industry and the public and providing these partnerships so that you could expedite innovation, I think was the key. I'll just say a couple other things really about this, and that is we use data in real time to help us make decisions. So as you know, we expedited decisions around diagnostics, therapeutics, vaccines. And some argued that we were, quote unquote, cutting corners. But it's like a doctor in the emergency room. You make a decision about a patient with the information you have at the time to save a life. And then when you get more information, you change the approach that you're using. In fact, patients want us to do that. Well, the FDA did that in real time, diagnostics being a great example. When diagnostics were first introduced, it was on contrived data. It wasn't, or contrived samples. It was not done in human beings. And then when we gathered real-world evidence, we went back and readdressed the performance and the indications and improved the tests. This sort of iterative process must occur as we bring innovations from the lab to the clinic and into the commercialization. We need to see more of that, and I think that's what worked for us at FDA, the willingness to do that.
Yeah, I think the other really critical piece from my perspective also was it was the first time the government turned to the private sector and said, I need this, and I need that, and then I need that, and then I need that. And they immediately responded, and the dialogue was continuous between the FDA and the companies to get what they needed in order to be effective, because part of it was supply chain and getting all of the different pharmaceutical pieces put together, the API to actually produce these pieces. I think that sometimes I spent 40 years in the federal government. Sometimes we think the private sector is non-responsive because we don't ever go to them and say, I have a problem and I need your help. And I think COVID really demonstrated us, if we go to the private sector and say, we have a problem, we need your help, they will help us solve it. And they did that without, I mean, they were working around the clock like we were, and that was what's so inspirational.
Without exception, that happened, yes.
Exactly.
Without exception, across all sectors. It's pretty impressive.
It was,
across the globe.
Yes, across the globe. It was just amazing to me, and I think sometimes we limit ourselves because we think they're not going to be responsive, so we don't ask. And I think what I really learned is ask. The worst that can happen is they say no. Speaking of asking, Palantir, I guess unfortunately, I had known them from my work in Africa with other pandemics, HIV, TB, and malaria. And so when this hit and I needed data quickly, the call went to Palantir. With a said, I need within days case numbers, all the labs reporting into a central mechanism. And this is thousands of laboratory tests. We got up to 2 million a day, all reporting in real time within 24 hours. Because the slope was as equally important to the actual number. And we'll talk a little bit about that and why that was so important. Tom, how did Palantir do it? I mean, how did you, and why isn't that being done for all of our health issues?
No, it's a very good question, and lovely to be here. And also extraordinary to see what Bahrain achieved during the crisis, the pandemic itself. But yeah, so how did we do it? Maybe very briefly, what is Palantir and what is Foundry, the software that we have? It's essentially focused around allowing organizations to work more collaboratively and improve decision making. And it achieves this through integration with diverse set of data sources, everything from legacy mainframes all the way through to modern cloud infrastructure and everything in between. And also integrating with models, so everything from deterministic models that you might find in Excel all the way through to large language models, artificial intelligence. And what really we're focusing on is investing in those connectors so you can rapidly integrate with all these different systems, then harmonizing that data, creating then a consistent data model that represents the fabric of public health in the United States, for instance, and then allowing these modularized decision-making applications to sit on top. So I think although we hadn't been, at least with significant depth, in public health, what we'd spent the prior 16 years working on is how do you integrate data, how do you integrate incredibly sensitive data, how do you manage access controls, granular access controls, coupling that with permissioning models, and bringing that all to a cohesive whole so that you allow thousands of people to leverage the same consistent source of truth. Now, of course, that's only the technology side. It wouldn't have been possible without the convening power of Dr. Birx and others. But I think one of the big successes was it wasn't just Dr. Birx who was able to use this source of truth. It was actually 30 federal agencies and 50 state health departments. So yeah, it was an extraordinary thing to be a part of, and yeah, many thanks to Dr. Birx for helping to make that happen.
You know, I think what people don't realize is how much a data-free zone creates misinformation. And I think we've sort of allowed that over the last several decades. So I'm going to ask you a hard question that I didn't even brief you guys on. Why do you think it is, in the day and age where we can diagnose the tissue type of cancer, the receptors that people have, the precision medicine around specific what we call CAR T cells, yet for every viral respiratory disease, we decided it was okay to guess, that we just thought you had flu? 95% of all flu diagnoses are presumptive. I mean, this is in the 21st century. How did we let that happen? I'll turn to you first, Dr. Jameela. How did we just ignore respiratory viruses?
Yeah, thank you so much. I think this is probably, if you ask most of the infectious disease consultants, they will, I think they have to, think about it before even they answer the question, but we'll try to answer it. In my opinion, I think we as, infectious disease community and even public health, we didn't forget the respiratory viruses in general, and I think we've been trained forever, residency, fellowship, and even, with working with WHO for long enough that we weren't trained for the next pandemic, epidemic, or outbreak, but nobody really give it the weight that you just mentioned, how it will present and how it will be transmitted, how it will impact, real impact. We're not talking about something like drill or just seeing it, but we didn't look at it that way. So I think we underestimated the power of these viruses, because all the time when you talk about pandemic, we talk about the ideal virus, which is airborne, transmission, easy, it can attack, thousands in one sitting. So we know that, but I think when it came to the real implementation, we were not ready for it. But just, going back to the COVID-19 pandemic, we noticed even before anything published that, like we'll talk about Bahrain, that Bahrain is really, we are a multinational, different background, people from different countries, plus the original people from Bahrain. We notice, and that's not only in Bahrain, even in other Gulf countries, what we notice is that the disease has different presentation and prognosis and outcome in different nationalities. We saw that in certain nationalities, people at younger age, no risk factor, they progress rapidly, even within hours, and they die, despite the other, classic, risk factor for COVID-19, like age, diabetic, cardiac, we're not there at all. So we're thinking about it, and this is probably get us to one thing which is very important, is having the genetic background in our thinking. And I don't think so it's only related to the respiratory viruses. Most of the other illnesses now, it is related. and we're talking about personalized medicine. And in Bahrain, actually, we had a program that launched earlier, before even COVID-19, and this is really supported by the government, which is the National Genome Program. We are, working on this to make sure that we have kind of genetic mapping in the Kingdom of Bahrain to be able, and this is very important for decision making, to know the disease impact, the progression of it, what resources you need, how you treat them, because we know now not all medication work equally among the people. So within COVID-19, it is now proven that people with different genetic backgrounds, because of genetic mutation, polymorphism, overexpression, they have different presentation outcomes. So that's a fact right now. I think we should implement it to other respiratory viruses.
Steve, so here's a hard question for the FDA. Why does the FDA allow physicians to prescribe flu medications without a definitive diagnosis?
Well, I don't speak for the FDA, so let's just make that clear right now. So the FDA does not regulate the practice of medicine. That, by statute, is not what the FDA does. The FDA labels and provides a label for drugs and for diagnostics and for devices, which then physicians use in their own interpretation in terms of sort of going into practice. Now, the question that I would ask is, unlike cancer, where 84.7% of new cancer drugs last year approved by the FDA had a companion diagnostic.
Exactly.
So our field, as oncologists, is organized around diagnostics and the diagnostic testing regimen. But I don't think that's absolutely true across all infectious diseases. So Tamiflu, the drug for flu, is it a requirement that you have a positive flu test as part of the label? And even if it is, do physicians have to practice that way? And they don't, even though it might be in the label associated with the FDA. So there's that step that occurs that might not be followed in the practice of medicine. I doubt there's an oncologist who would treat a person for adenocarcinoma of the lung without a tissue diagnosis of adenocarcinoma of the lung. The second point I'll make is that we, in the, I think, medical innovation field, incredibly undervalue diagnostics. And diagnostics are the key in terms of identifying, gathering, and then communicating information about disease. We need to do a better job of that.
Palantir, and then we're going to turn right to the audience for you to ask questions of this incredible panel of my real heroes. So from Palantir's perspective, it's not just collecting the data, it's making that data visual so that anyone, a governor, the president, the head of the HHS, can immediately look at it and know where we are and what we're doing. How do you do that? Bring data, because you talked about bringing the data sets together, but it's the visualization that becomes really critical.
Absolutely, and I think it's also allowing users to leverage data in the way that they've already used it before. So it's really about interoperability and radical interoperability. If they're already using a very specific dashboard, that should be able to connect to an underlying data model that is harmonized and cleansed. But I actually would go a little bit further. I think it's not only about the visualization of the data in terms of the application that sits on top, but also understanding the flows of data beneath, because I think that provides not only transparency, but also trust in the data in which you're working with, because you understand where it's come from, what systems it's leveraged, and the various different intermediaries that have occurred throughout this path. And I think one more point I would mention is it's also allowing decision-making modules. What we found in the UK, for instance, is we're able to integrate with PPE systems across the country, inventory management systems, and we're able to, of course, show in visual terms the real-time stock levels across the country. But it was only when individuals recognized that how they filled in those submissions of how much PPE they had at any particular moment in time had a downstream impact to how much they would receive, it completely changed the behavior. And so really allowing individuals to wrestle with that data and make decisions that write back to those underlying systems, that's where you really can see a behavioral transformation as well.
Tom, I think that's such an incredible point that's critical for the audience, is when they know that all of this, because reporting data, some people would say it was tedious, But when they see that people are using it to get them what they need, they really improve the data quality over time. And that's what's so important, and that's why I think having these databases, like what Bahrain is doing, keeping their databases going. All of our databases have now been taken down that we used during COVID. All the hospitalizations, we had 100% of hospitals reporting in real time. All of the lab data that was being reported, it's now, we're back to wastewater and counting beds. So we're not in the best shape for the next pandemic. You all in the audience, I want you to, I know there are people in the back are listening. Please get the microphones out and raise your hand, stand up, and we'll get a microphone to you. We have 9 minutes right here in the front. Stand up and we'll get you that microphone really quickly. Someone's going to run to you, I know. And can we get another hand up so we can, great, right back there, get another mic. 2 hands over there, get those microphones to them, and we'll go right to them.
Hi, my name is Dr. Mark Davis, and I want to start by thanking you for really the astounding work, speed, professionalism that saved an incredible number of lives around the world, so our deepest appreciation. We often in medicine talk about the retrospectoscope. So I'm interested in your opinions. If you knew then what you know now, what might you do differently?
Oh, great question. Let's start with Tom, and we'll go up this aisle.
I think one aspect is just how critical leadership is, leadership at the very top. Technical problems exist, technical challenges exist, but I think it really is around the convening power of leadership, whether that's the White House or the Cabinet Office in the UK. Those are the individuals that, when a mandate was actually channeled through the system, you saw incredibly fast changes. I mean, I mentioned PPE, but really in the space of 48 hours, you had every single hospital in the country reporting live data. So I think leadership is something that if we spent a little bit more time on making sure that we were discussing with those who had that mandate power earlier, rather than focusing purely on the technical problems, we may have gone even faster than we did.
Steve?
If I had known that we could maybe push some of the boundaries of the industry agency collaboration, I think starting that even earlier than we did would have been important. There's a very bright line between the sponsors, that is industry, and the agency for good reason. But that needed to break down a little bit in order to actually facilitate the development. And so that ultimately led to what Deb talked about, which was rolling reviews and constant interactions. Frankly, I wouldn't wait for the next pandemic for that to occur. That should happen right now with the appropriate oversight. So that's probably what I would have started earlier.
Jameela, real quickly.
Yeah, I think it's just, if we knew more about this virus, at least within the COVID-19, we started early, but we probably started earlier. And I think what we learned through the COVID-19 is how much we have to trust our own people and the talents and the experience we have, and really analyzing our data earlier in the pandemic.
Yeah, my biggest take-home message is we were better prepared in the countries where we were already fighting pandemics, whether it was HIV, TB, and malaria, because we understood that intersection between technology and community. And so we understood constant community education and engagement is critical, and I loved its ambient, active listening is critical. I think that was difficult in the US in particular. Okay, we're gonna take both of these questions together.
My name is Majid Ardati from Bahrain Specialist Hospital. I'd like to thank the panel for their very insightful comments on this topic. My question has to do with sort of the scale that we've seen in Bahrain. So as the panel mentioned, 1.8 million people in Bahrain is not quite sort of the larger scale that maybe other markets have seen. How does that impact sort of the quality of the data and sort of the consistency of having it going forward? And the second question is from the private sector, I'd really like to understand how we can continue to benefit from this interaction, because having more information, having better communication, better partnership between the public and private sector really helps us understand where we need to go in the future, where we can continue to support, and also consider it as a regional issue. Bahrain, like we've also said previously, is a smaller market, but how do we also integrate with the region on that level as well? Is there a role for sort of a regional collaboration or partnership as well? Thank you very much.
Great, and do we have that last question back here?
Hello. Yeah, my name is Ali Khazil from the Economic Development Board of Bahrain. First of all, thank you all very much for a great panel discussion. My question would be, as we see more and more frequent and quicker innovations within the pharmaceutical sectors, medical device sectors, clinical techniques, etc., how can reference regulators across the world keep up with these new submissions from these new developments from existing markets as well as developing markets moving forward?
So, and your wrap up, and I'm just going to go straight down the line, answering these two questions about regional cooperation and broad markets and this economic and approval process. Straight down the line with your wrap up, whatever else you would like to say.
Okay, so probably answering the first question, I think that private and government partnership has been established in Bahrain. We have really great experience and good outcome through the COVID-19, and we are maintaining it. And probably you heard through the last panel discussion is that now even within the Supreme Health Council, which is the highest umbrella, there is a huge representation of the private, and with the insurance when it comes, I think you will see more of the private going forward, and it probably will take more percentage of the health system in Bahrain. The other part of the data and the quality of data, yes. Within Bahrain, I can speak about the team. These data have been filtered and revised several times before it's been put in the dashboard to make sure it's high quality data to be represented to the decision maker to make their decision. Probably in other countries, more efforts has to be done, depends on the size of the data that they have. Steve.
Yeah, I'll speak to the regulatory side of things and the public-private partnerships. I would probably not refer to it as partnership, just because there's a oversight portion of this that's important for the regulatory bodies. But that doesn't eliminate the fact that what worked during COVID, and that is a free exchange of information in real time back and forth to either fail early if your therapy or vaccine's not going to work, or give guidance on how you can make something work better, and then post-marketing continue to improve that. That absolutely must continue. And that is what we've seen, this drift away from that, certainly at the US FDA. We need to have that back, because it's in everyone's interest to stimulate innovation into the hands of providers and patients. And that's going to be an important part of it, that middle regulatory interaction between the private sector and the government.
Tom.
And then maybe very quickly, just picking up on the scale of Bahrain question. Of course, Bahrain is a much smaller country, but I think where the opportunity lies is perhaps not in the scale, but in the depth of innovation that can be scaled right across the country. I mean, it's incredible to see how you've already integrated primary, secondary, and tertiary together. And what that bedrock, that data foundation is going to allow you to do is really to be on the forefront of how to scale AI, diagnostic models, large language models, automating back office functions of hospital operations. I think a lot of the bigger countries, just because of the scale of fragmentation, it's going to take a lot more time to really see those benefits. So yeah, very excited to see where Bahrain goes from here.
I just want to really thank the panel, because they represent a large group of people that stand with them, beside them, behind them in addressing this global crisis that we've all lived through together. And I just want to thank each of them for their leadership and for willingness to share, and us all learning together as a global community. I hope that that translates into how we work together in the future. Thank you.
Thank you so much. Thank you. So thank you so much for, I think, the nice discussion. And we'll move to the next panel discussion, which actually, you know, we're really glad to have you again with us here. And it is under the title of Healthcare Diplomacy Across Border. And really, we are, you know, welcome His Excellency Andre Catalano, who is the Italian ambassador to the Kingdom of Bahrain. And, you know, the ambassador of United States of Bahrain, he is on his way, as far as I know. So Ambassador Stephen Bondi will be soon joining us on the stage. So please, you know, you can join us, and then the U.S. ambassador will join. Thank you.
Great, thank you. And this gives me the opportunity to really highlight what the ambassadors and His Excellencies did for us. And I'm just thrilled to have Italy here, because what many of you may not realize in the audience is in their very depth of their own catastrophic situation, Italy was sharing its data with me nightly. And it was the way, and that they were about 2 weeks ahead of the United States. And they, even though their hospitals were overwhelmed and things were incredibly difficult, they sent me every piece of data from their hospitals, who was being admitted, what were their ages, what were their comorbidities. And so we could go out to the United States population with the Italian data and tell people precisely who was at risk, why they were at risk, and why this was important. And I just want to thank you, because you saved a lot of American lives with that incredible work that your ministries of health and your hospital personnel, who didn't have to. I mean, they were busy, but they made sure that we could learn from you in real time. And that was really extraordinary. What has, and we'll also talk to our ambassador here, that was done very informally. What since then, do you know, has been set up so that high-income countries and middle-income countries, and I'll just, as a little aside here, for decades we prepared for pandemics with the hypothesis that if we build capacity in resource-limited settings, that's where most pandemics potentially would originate, and that we would see it and be able to detect it and respond early. None of us contemplated a pandemic that preyed particularly on the elderly and those with comorbidities, and that would strike high-income countries at a much greater rate because of those comorbidities and because of the age. Is there a system now where we have that sharing of information in real time?
First of all, good day to all. Thank you for having me here. This is the informal part of the panel. We're waiting for Steve. So I was, at the time, I was both actor and subject of this. I mean, I was locked at home, watching probably you on TV from the White House and our own. I think we learned a lot, you know, by doing. By collecting this data, by sharing this data, and we learned to cooperate openly on this challenge that none of us was technically ready to confront in this scale. I don't want to go ahead of the 2 notes that I wrote in for myself, but at the same time, as we were on our knees, we relied on our friends to help us. And as soon as we were ready, we went out and help those who need it, both by sharing data and by pushing the multilateral production of vaccines, the distribution, and so on. And this continued after the pandemic. As a diplomat, I cannot predict what the next is, but definitely I'm sure that we're more prepared to address it in a cooperative way, with both between high-income countries and those more in need.
Yeah, I think that's such an important concept, because I had spent the last 20 years in Africa and Asia working on HIV, TB, and malaria, and I think you all know that we're having a pretty significant dengue issue in the Americas, probably the most significant dengue that we've had ever in the Americas, and that information is being shared in real time, which I think is incredibly important. And I think what I learned and what I've learned from the diplomats is our diplomats around the globe weren't specifically health educated. I mean, they have to cover economics, they have to cover finance, they have to cover all of these other issues. But I will tell you that all of them learned about respiratory diseases, how they're transmitted, PCR. All of them can now talk about PCR and the global hospital cooperation. And I think that global hospital cooperation, you all should know, was happening in countries among the diplomats, and then across countries by the diplomats that were in those countries, that were assigned to the United States or other countries. And that to me was really phenomenal, is how many of our ambassadors from all the different countries really were there, often in missions that were empty, and they were the only ones there, working to make sure that information was shared in real time. Italy was critical to that and really sharing of that information. But so were the countries, and we talked about how important Bahrain was. The Middle East is where we really all got our vaccine durability information from, and how long and what the interval of vaccination had to be. And I think our diplomats, a lot of their work is behind the scenes and you don't get to see it, but I think for the first time, we all in the healthcare structure realized how important these relationships in countries, between countries, really were, because none of us had prepared for a pandemic that differentially impacted high and upper middle income countries. We had prepared for the opposite. Now, I'm looking at the teams to see if our ambassador has arrived. Possibly perfectly on cue. Excellent. Ambassador, welcome. Good to have you. We have our great ambassador, His Excellency from Italy, and now our ambassador, the U.S. ambassador to Bahrain, Ambassador Bandi. A foreign service officer there. We were just talking about how our ambassadors are unsung heroes in this pandemic, and I think hopefully they're going to write up what worked in countries, between countries, because I really benefited from being in the State Department and knowing the importance of our ambassadors, but also being in Washington where all the diplomatic corps from all the world resides. And so now we'll turn to the questions. What have you really seen, both of you, and what has been the most important developments in healthcare diplomacy in the last decade? How have you found that? Many of you have been assigned to different countries. You have a lot of awareness. I'll turn first to Ambassador Bandi and then His Excellency from Italy.
Thank you so much, and apologies for running a few minutes late. My assumption was that every conference also runs a few minutes late, but clearly the C3 conference is different. So well done, all of you, keeping us on schedule, and it's a real honor to be here. With your permission, I can maybe answer your question, but going into a little bit of detail.
Perfect.
All right, and then of course we can do any follow-up as well. So first, truly, it's a great honor to be here. I see many friends here in the audience, and it's not often that an ambassador or a diplomat is speaking to a group of healthcare experts and professionals. So it's a new experience for me and a great honor. And it's wonderful to be here with you, Dr. Birx, and with Ambassador Catalano. And you know, very much I'm looking forward to hearing what comes out of this panel. And just before I jump in, I want to say, Dr. Birx, I just really admire your commitment to national service and science. in the face of great challenges, and really that's the definition of integrity. Good on you.
Thank you.
And of course, many thanks to the government of Bahrain and to the American Mission Hospital for bringing this stellar C3 Healthcare Summit to Bahrain. I hope I'm not repeating what you already know, but Americans first came to Bahrain 130 years ago as missionaries from the Dutch Reformed Church of America. And they came to do what? To provide health care and other services, humanitarian services. And the hospital, the school, and the church that they established still operate today. They're just a few minutes drive from where we're sitting right now. And of course, the new King Hamad American Mission Hospital opened just over a year ago, and it represents only the latest culmination of the work those missionaries started. The facility offers world-class care for its patients by employing the most advanced approaches to prevention, diagnostics, and treatment. The partnership between Bahrain and the United States in the healthcare realm now includes advanced scientific research, opportunities for Bahraini medical students at American universities and research institutes, and growing collaboration between the most modern and sophisticated healthcare institutions, equipment and pharmaceutical manufacturers, and service providers. Last fall, the American Embassy supported a successful healthcare partnership forum which brought together U.S. and Bahraini hospitals to build professional linkages to promote the best possible health outcomes. In September of 2023, His Royal Highness Crown Prince and Prime Minister Salman bin Hamad Al Khalifa signed the Comprehensive Security Integration and Prosperity Agreement with Secretary of State Blinken in Washington. In addition to security cooperation, the agreement emphasizes the importance of closer collaboration in trade and investment and in science and advanced technology. The agreement provides a turbo boost to our bilateral relationship and establishes a new platform from which we can work together, including in the healthcare realm. Partnership in healthcare initiatives, technologies, research and development is a crucial way we give life to this agreement for our nation's mutual benefit. The United States healthcare diplomacy is a global endeavor reaching every corner of the world. We are the largest single donor in healthcare. In 2022, our government delivered some $17 billion in foreign assistance globally to address health issues. Our focus is on combating a range of infectious diseases like Ebola, Zika, polio, malaria, and tuberculosis. Delivering health care can bring together people and organizations not normally predisposed to work together. When I served at the U.S. Embassy in Kabul, Afghanistan, the U.S. Agency for International Development had extensive programs to bring health care to Afghans. This included innovative methods to administer polio vaccinations in remote areas. In many cases, our contractors found ways to work with armed groups that were aligned against us. But even they understood that healthcare should be far away from politics and should focus on helping people. The White House has a number of global health-related offices to drive government engagement. These include the Office of Pandemic Preparedness and Response Policy, the Health Outcomes Team, and the National Security Council's Directorate for Global Health Security and Biodefense. In 2023, the U.S. Department of State, which is my home organization, launched a new Bureau of Global Health Security and Diplomacy to use American diplomacy to bring the world together to prevent, prepare for, and respond to global health threats. That bureau is now headed by Dr. John Nkengasong, who is globally recognized as a leader in combating infectious diseases. As a career diplomat, I would not say that generalist foreign service officers are necessarily qualified to work in health diplomacy. The State Department is now embarked on an effort to bring in that expertise, which, when it's paired with diplomatic tradecraft, will help build health resilience globally. The United States collaborates with countries around the world to strengthen public health systems, including labs and supply chains, to better address current and future health threats alongside our national, regional, and multilateral partners. We work with Bahraini counterparts to promote academic collaboration, professional exchanges, and economic cooperation. We believe these initiatives will promote good health care and improved well-being for the citizens of both of our countries. Thank you.
Terrific. I'm turning to you, Ambassador Kaulana.
Thank you. I'd like to cheat and just say what he said, at least in thanking everybody, but I'll do it anyway. I want to thank Dr. Cheriyan, the American Mission Hospital, and the other organizers of the summit for inviting me to participate in this extremely important panel with such distinguished friends and colleagues. Dr. Birx, you're famous for all diplomats.
Infamous.
And citizens of the world. As I mentioned, during while I was in lockdown, we would watch you from the White House and listen to what you had to say. And take example. As we were providing data, we were also taking data. Before diving, and as Ambassador Bondi, as a diplomat with no medical expertise, I am still a little intimidated. But one of our traits is to improvise and, place ourselves anywhere where we stand. You put them there. So I hope to not embarrass myself completely. But before going in a deeper dive on the subject matter of multilateral dimension of healthcare diplomacy, I just wanted to mention what Italy does in putting medical and humanitarian support at the fore of its diplomatic efforts. The latest example is what we did in favor of injured miners in Gaza. We moved a Navy multi-dimensional ship, and we medevac a first group of children who were then transferred to Italy. A second group was transferred to Al Arish, and then from there to Italy. In an interesting twist, the patients of this second group were triaged in Cairo in the Ospedale Italiano Umberto I, who also shares a history, a centenary history as the American Mission Hospital, and is still there providing top healthcare for Egyptians and people living in Egypt. I'll stop here for the moment, but we can move to the more multilateral aspects of the conversation.
Well, I really appreciate your comments, because I think it really speaks to C3 and why Ransel saw this as an opportunity, because he understood back in 2012 that there was this intersection between foreign policy, health policy, and the global world responding to pandemics. And I would say in general, I've worked all over the globe. What has frustrated me is we often will have foreign policy discussions around security, but we never bring in the health security piece. And I think we've learned from COVID that if we don't pay attention to health security, it can shut down the world. And I think we've all learned a lesson from that. How are your countries, and how are you talking among other diplomats of what you see as the challenges of all of the diplomatic force working together in real time? And what would you like to see from the health world to really support that? Ambassador.
Sure, thank you. Well, Dr. Birx, you really hit on it. I mean, I think COVID-19 brought everything into focus for diplomats, for healthcare professionals, for the whole world. Look, health threats such as COVID-19, Ebola, HIV, AIDS, and many others continue to demonstrate that, in fact, health security is indeed national security. We see that very, very clearly now. Viruses do not respect borders. They do not remain contained, and we sort of have to be ready for what's coming. And I mentioned a few minutes ago our new State Department Bureau of Global Health Security and Diplomacy. As you know, we were already working in this area, but it was healthcare diplomacy was built into other bureaus, whereas now the idea is to have a direct focus on it. And if I can use an analogy, the reason that we've done this is to develop and grow a more robust network. I can assure you, the United States does not have all the answers. The way that we work well is by having strong, robust international networks, in effect, early warning stations about things that are happening. So this linkage between diplomacy and healthcare is all about the public health realm, and that is to get ahead of the problem. So when something is blossoming, a new virus, a new disease is blossoming somewhere, we're kind of ready for it. And during the quiet times, we are preparing to react if we need to. Another area I just want to touch upon briefly is in HIV/AIDS. So this is a real point of pride for the United States government that we have been working in this area now for over 20 years with really a focus on Africa. We had a program called PEPFAR. I'm sure you're all aware of it. And according to the statistics in 2003, only 50,000 people in Africa were on life-saving HIV treatment. As of about a year ago, PEPFAR had saved 25 million lives and was supporting over 20 million people with treatment globally. As far as COVID goes, the United States has provided almost 700 million doses of safe and effective vaccines globally. And, you know, in addition to the health challenges, I think COVID also uncovered for us all to see how fragile our supply chains were. And this is an area where we were working specifically with Bahrain to try to build up the supply chains of equipment and key medications. And if you allow me to talk just very, very briefly about a political matter, and that is that right now Bahrain and the United States, among many other countries, are working to protect commercial shipping in the Red Sea and the Gulf of Aden. Look, there's a direct connection between what we're doing there and the availability of medications at competitive prices here in Bahrain and across the world. You know, whatever the Houthis claim that they're doing, what we're seeing is disruptions in supply chains, lengthened transit times, and who does this affect? It affects you know, your average citizen, which is why we're proud to work with Bahrain in this field. Thanks.
Yeah, I think you really raise important points that there's an intersection between infrastructure and supply chain and health, which no one really paid any attention to when everything was working perfectly, but now we actually know that there has to be a global community around supply chain and where we're going to have surge capacity and where our API, our starting pharmaceutical components come from so that everybody can have access. Italy is known, and the reason your data was so important to us is your innovation in healthcare delivery and your scientists that are so critical for doing discovery and innovation. Can you speak a little bit about this question of the next pandemic, your next concerns, and how you're working that within the diplomatic structure?
Let's take a step back. Also, first, thank you, Ambassador Bondi, for mentioning the Gulf of Aden and the Red Sea. Italy, as you know, is actively commanding one of the missions there, from Bahrain, actually, and we're proud to do that. Interesting that to see the twist of events, that the pandemic undermined the global supply chain when everybody could work, and now security is affecting, in the other sense, supply chain and the distribution of pharmaceutical. I mean, things, a catch-22 that turns around. So I have to say that COVID-19 pandemic has been one of the most consequential events in the health. I mean, not to diminish the relevance and the impact of other pandemics as Ebola and HIV/AIDS, but this just caught us all throughout the planet unawares. We learned a lot. So Italy, as you mentioned, aside from providing data, was one of the first and heavily affected countries. We had to rely, luckily, and this was thanks to healthcare diplomacy, on the help and support of partners throughout the globe, even some who today you would not go around with. But no, we had help and support. And the moment that we got back on our feet, so to say, we were able to exchange a favor and start supporting others. So both directly and in the multilateral realm. So we were one of the countries supporting the COVAX facility. We provided millions of vaccines throughout the world. And then we transferred this effort in the multilateral arena, both in the European Union, but also in the G20 presidency that we had in 2022, in which health was front and center, especially in that format in which you had cross-section of the world. We're keeping that commitment on the multilateral level with our current G7 presidency. And we hosted earlier in February, I believe, a specific health ministerial which approved a declaration dedicated to prevention. I have to find it, but importance, urgency of improving global health architecture and pandemic prevention, preparedness, and response. So this is to responsibilize, the big seven, but also others in deepening the cooperation. One thing that we learned is maybe we're not that prepared, that the multilateral aspect of this response is crucial. We are all thriving and working to establish a functional and not repetitive architecture in which all our efforts can be streamlined, so no duplications, and aimed in the right direction, both in the exchange of scientific information, in the emergency response. Let's say the last 4 years taught us a lot. Some may have been prepared, but throughout the world we were not, and we were caught a bit unawares.
Yeah, and just in concluding, because I know everybody's going to want to have a lunch period, what agreements or underlying vehicles, Ambassador, you mentioned this comprehensive security, integration, and prosperity model. You just talked, Ambassador, about a pandemic preparedness agreement. Are these the structures that we need to bring us together and united in our response? And do you see that there's still a gap?
Yeah, well, I would say necessary but not sufficient. Surely multilateral organizations really provide the connective tissue between countries around the world, and the World Health Organization to start, but many, many others, several UN bodies are involved in health care issues. But if I could just for a moment talk about this agreement that you cited, it's really a strategic security agreement. So I would say defense and security are pillar number one. Pillar number two is trade and investment relations. And three is work on science and emerging technology. So you can actually see how healthcare covers each of those three areas. And I won't belabor the point, but I can really see this agreement serving as a platform for work in many, many healthcare-related areas. Now, it's relatively new. It's been around, I believe, now for 7 months. And unfortunately, at least for the United States point of view, the very people who would have been working to activate the agreement were all moved in and are really focusing on Gaza and the situation there. So I'll admit we haven't done as much work as we would have intended, but we are now kind of getting ready to activate. And we're looking for ideas. And I think, you know, I've touched upon a few things already, be it more students coming to the other countries. Research and development really provides a very logical area to expand our cooperation. But additionally, the companies, and Bahrain has formed what they call the U.S. trade zone, which is kind of in a very strategic area of the primary commercial port, and they've set that aside for American companies to operate. And I agree with the argument that, you know, Bahrain is a small company, so if a large manufacturer of medical equipment or pharmaceuticals were to come in, look, Bahrain will purchase some of those items, but really it could be a fantastic source of exports for much needed medical equipment and pharmaceuticals for the region and globally. So I guess watch this space. We're not quite sure how it's going to turn out, but I'm very optimistic that there will be new initiatives coming out of this.
I think you weren't here for Jameela's talk, but she presented the reason she felt, and I think the WHO felt, that Bahrain was so successful is they created a horizontal structure, bringing together all of the different agencies. And what was exciting to me when I heard about the agreement is it transcends a vertical multinational agreement into a horizontal and recognizes that all of these elements have to come together and work together for us to be successful. And I think that's the piece that's missing out of many of the UN stovepiped or the WHO stovepiped health pieces, to find that horizontal piece that brings together. I mean, we have to remember, we were short of the private sector production of different elements that were needed in COVID. And so we can never ignore the private sector in all of this. You've talked about, and we'll just close with this, you have comments about this new structure that you're working on in the pandemic response, and what you see still is the gaps, and how we get, who is going to put together the horizontal structure that we all need besides Ransel and C3, because I think he sees it as horizontal also.
So I don't have the answer to that, and I would be, despite improvising, I would be remiss in trying to score my way out of this. But definitely, no, one thing is that let's not underestimate the existing structure. You both mentioned the WHO, which is the heart of our efforts. And we must somehow streamline all new strands of effort, further strands of effort within one platform, which does provide the horizontal structure. One takeaway I'll have from this is what Steve mentioned. Sorry, Ambassador. Having the capacities within the Foreign Service to address. So we don't have them. We're mostly generalists. And I'm not sure we'll be able to have a specific bureau, but definitely having in the main embassies a dedicated health related. We do have in Washington, for instance, but that's an exception. Here I don't have a medical expert, but definitely it's something that would be beneficial to our multilateral efforts in diplomacy.
Terrific, and I want to thank the audience for listening so carefully. I just want to end with one of my concerns about our existing multilateral and multinational structures is they're often adverse to working with the private sector. And I think what we've all learned is the private sector was key to us having what we needed to respond, whether it was tests, whether it was PPE, whether it was treatments or vaccines. And I think we all have to step back and realize that the private sector is an engine that we need in the healthcare delivery system, and all of the multinational groups, including WHO, has to develop close relationships or a closer relationship with the private sector in order for us to be effective in our response. I want to thank both of the ambassadors for taking time on a Sunday away from your families to come here and really give us your new insights of these new vehicles that we can utilize within the diplomatic space to really interact in a horizontal way. And I just want to again applaud Ransel and George for putting together a horizontal conference that recognizes innovation, infrastructure, and healthcare, and how often they're linked, as well as our security of working with each other. So thank you very much.
You're welcome.
Thank you for the great discussion that we had so far, for your excellency for being here with us today. So ending this panel discussion, and another thank, because they finish earlier than the time, 10 minutes, so that will be added to your lunch break, so you can enjoy it and have the prior time and lunch. So please, we'll be back on time by 1:45 p.m. Thank you, and see you in the next panel. Yeah. Thank you. Welcome back and good afternoon, everybody. It's good to have you back, and I hope you are still awake after this lunch. You know, nobody will, sleep. We'll have really another 4 sessions, and I'm sure they will be really very exciting to all of us, and we'll learn a lot from these sessions. So the first panel discussion, actually, now we'll start with it. It's under the title of Innovation and Sustainability in Healthcare System, where we'll have the moderator is Dr. Sabi Dorotifix, who is the President Mount Sinai International, the Mount Sinai Health System from United States. And the panelists, we have 2 amazing speakers. We have Dr. Sunil Chandi, who is Medical Director, ITC Healthcare Project from India. And we have with us also Dr. Mark Davis, who's the President of Oximage Global Healthcare from United States. So please, for the moderator and the panelists, welcome on the stage, please.
Good afternoon, everybody. Well, I certainly hope, as the announcer said, everybody is still awake, and we will have a very interesting and meaningful discussion here, and we will want to hear your thoughts as well. First and foremost, I would like to ask my fellow panelists to introduce themselves.
Good afternoon. My name is Dr. Mark Davis. I am an emergency physician by background. Had the opportunity to work in Boston at Brigham and Women's Hospital and Harvard Medical School for 25 years, and the great privilege of doing a fair amount of work in the Middle East with many colleagues here. For the last 2.5 years, I was the Chief Operating Officer of Baptist Health Cancer Care in South Florida. South Florida's largest healthcare system. About $3.5 billion in revenue in the cancer care program, and had the opportunity to do an operational turnaround there. I'd also like to say I really enjoyed our speakers previously, and had the opportunity to do a fair amount of health diplomacy over the years as well in this region. So, privileged to be here.
My name is Sunil Chandi. I'm a cardiologist by training. In clinical practice for a good 30 years, but have moved on from that to medical administration, and I work for a company which is a corporate company in India who are far away from healthcare but have made a commitment into a social model of healthcare for the community. My background is largely not-for-profit, charity, teaching institution, one of the biggest private hospital networks in India, which has got a common legacy with American Mission Hospital because it's also affiliated to the Reformed Church of America. So it's a pleasure to be here to discuss things that are of significant importance in the field of healthcare as we look into the future.
Well, thank you both. It looks like we have a panel of former physicians who wanted to leave the profession and do administration. I am also a physician by training, emergency medicine, and I am currently leading the international ventures at Mount Sinai Health System in New York. Our health system is the largest healthcare provider in New York, and we are one of the top academic medical centers in the country as well. As such, based on these introductions, I think you can all see that where we are coming from and what kind of input and what kind of thoughts we may have about sustainability and innovation. So we will talk about clinical, and we will talk about, of course, the business side of healthcare today when it comes to innovation and sustainability. Lastly, I would like to just say thank you, Ransel, for allowing us and allowing me to participate. It's truly an honor, and I hope that we are not going to disappoint today. I would like to start with sort of outlining the context for our discussion today based on what we heard, what I heard earlier today in the keynote speeches and other panels. We heard that there is a crisis in healthcare. There's a global crisis in healthcare, and the global crisis really focuses around the shortage of workforce and cost pressures, right? We also know that this is not only a United States or Middle East or Europe problem, it is a global problem. So how do we address this crisis? How do we get out of this crisis? Is going to be one of the main themes today. The second piece is that, yes, there is a crisis, but there are many new things happening in healthcare. We have new technologies coming to us every day. We are, as we learned from Dr. Cosgrove, we are doubling healthcare knowledge every 73 days, and we don't know what to do with it or don't know how to deal with it really. So these are not only, this is not the crisis part, this is the opportunity part that we are also going to address. And lastly, I would like to focus our discussions around two main themes, or three main themes rather. One will be the question of how do we address this shortage of human resources in healthcare? How do we improve? How do we optimize the utilization of our workforce? The second will be technology, how technology can help us. And the third, which is kind of technology, but I think it is more future-pointing question about artificial intelligence and what is it? How is it really helping us? How is it really enable us today? So first question to my panelists, colleagues here is, how do we improve utilization? One obvious way really is to improve processes, right? So what are there proven methodologies, best practices to improve physician, nurse, and other healthcare professional productivity?
I'll start with a story, actually two. The first, when I finished training, I went down to NASA as a National Academy of Sciences fellow, and there was this whole new thing called telemedicine, and we were working on how we were going to take care of the astronauts on the space station. And at the time, I flew around the country to all the major academic centers, and I was told that telemedicine was going to take over in the next 2 years, and that we should be ready. And it wasn't until the COVID global health crisis, 25 years later, that we really saw telemedicine take off. So it really emphasizes to me part of the context of this important conversation, which is all of the things that we talk about innovation are a tool to an end. And Dr. Cosgrove spoke about what some of those ends are, some of the things that we have to tackle. The huge amount of data, the workforce issues, and then the extreme margin pressures. And so I would say that we have to see all of these things within that context. I mentioned that I was, the last couple of years before doing my consulting work more generally, we did an operational turnaround at Baptist Health. It's a great facility, a new cancer care program, and we had a $100 million margin turnaround in about 2 years. But that comes with the context of really doing the essentials correctly. What's the strategy, what are the goals, objectives, metrics, and then plugging in these new technologies where they're most appropriate. So I'll start this conversation by saying that in fact this is an important part of taking a step back to a very disciplined approach to either building new health facilities, which I had the opportunity to do as Vice President of the Brigham, or advancing different systems. But good old business discipline that we learn from other industries is really the foundation for bringing in innovation.
Thanks, Mark. let me put a perspective which is largely from the part of the world that I come from, the Indian subcontinent. It's a little different from the United States or the Western world, who seem to be, in my opinion, far more ready for this, new directions that this churning is providing us. Clearly, COVID was a time when the world realized the potential of technology. And yes, telemedicine did come in as a big savior when it was not possible to have physical connections between doctors and patients. There was no movement, there were lockdowns. It was technology that actually provided that scaffold which helped many, thousands and thousands of people to get that basic medical help. And it's just taken off from there. Today it is not just related to a crisis situation, but even in our normal course. In the new world order, we find that telemedicine is being harnessed a lot more in clinical practice, in teaching. It has come into subspecialties like radiology, telepathology, etc. But your question was, how can we improve utilization? And you alluded to this crisis that healthcare is facing globally. I understand that there is a crisis which is global, and it affects us in India too. We see two problems. One is there is an unusually high attrition of the medical manpower, the young doctors, the middle-level doctors, who are the future of tomorrow. Attrition from the ranks of established medical systems. Where they are going, we do not know, but there seems to be a burnout, a jadedness that we see. There is also this feeling in medical students and postgraduates, and this morning we heard about how it is necessary to integrate new technologies into medical teaching. But there is a misperception, I would call it a misperception, that artificial intelligence will now obviate the need for good clinical training. I tend to disagree with that, because foundationally we are physicians, and a lot of it comes from that soiling of hands, that difficult night of researching, opening the textbook of medicine, asking questions, and that whole element of mystery that is in the field of medicine. If we were to be provided ready-made, spoon-fed solutions which AI can provide today, there is an element of doubt as to how good we will be as physicians. We'll come to what AI will do at a later stage. But the way to utilize AI is to actually position AI. It's an amazing development in a new direction. But it's important for some group of the medical faculty to position artificial intelligence and technology. It's very important where it is placed. If it's going to be an all-encompassing development which will put doctors on the side and many things on the side, I'm personally not very sure how much we will go ahead. And I speak from a perspective that is very Indian, that we have lots and lots of unhappiness, lots of patient dissatisfaction already, even before the AI systems have kicked in because of gadgetry and devices and all that. For the 70% of the Indian population that has no access to healthcare, they're rural, they're not digitally savvy, they're not educated enough. That's why I began by saying that it's a little different. And I guess Bahrain and places in the Middle East are juxtaposed between the Western world and the Eastern world. So how much this relates to you, I'm not sure. We'd like to hear from you. But it's important to moderate it and bring in the regulations required as to where and how and when this matrix of new technology can be fused with medical education and medical practice, so that finally the end beneficiary, the patient, will be the true beneficiary.
Can I make a quick comment? And it is, again, taking a step back, because I agree with your statements. But before COVID, and my colleagues can comment on this, we saw something quite amazing. If you looked at disability-adjusted life years and years of healthy life lived before COVID, over about the past decade or so, Chris Murray's work and others showed almost a 10-year improvement. So even without these technologies, with basic public health measures around the world, we were seeing, so the flip side of this crisis we're talking about is that great progress was made over the last decade. We do face new challenges, but I think it's really important for us to kind of see this bigger context in which we're working. We have a new reality, but in fact, as COVID is hopefully now behind us, maybe something else is coming, we do have some experience in making things better around the world, and some of it is just by fundamental, basic public health care.
Thank you both. I think that it is very important to address these topics in depth. So maybe we can break it out into very specific areas, if you agree, and dive into those. I would just start by history, right? So back in 2001, the Institute of Medicine in the United States came out with the report "To Err is Human." Hopefully many of the members of the audience heard about that. That was the change agent in the United States to improve quality and patient safety in hospitals, and as we heard, Dr. Cosgrove started in 2004 at Cleveland Clinic. Same time, when I was at Johns Hopkins, the program became first priority for our institution as well, and since then remains top priority everywhere. What happened? Besides, you know, we learned that, oh my God, many people die in hospitals for no reason, or for avoidable reasons. What happened is that we learned from other industries. We learned process improvement protocols, standards, procedures that help us, and adapted to healthcare and made improvements. Now, you know, I shouldn't mention, but one of the industries was the airline industry, so maybe it's not the right time to talk about that, given what's going on at Boeing. But certainly, it is something that was a success story. I feel it is a success story. So where are we with that right now? So, you know, it's interesting, the airline industry analogy. Air travel is still the safest way to travel, right? And there are obviously issues that we all hear about with one of the major American maker, Boeing. And it really points to how you make progress in any industry, which is you have to have systems solutions to any problem. And many of you will, you know, see in your health institutions that a problem pops up, and I call it sort of whack-a-mole, and we're going to look at that problem and we're going to try to educate our way out of whatever issue there is. And I think if there's one thing that we've learned, whether it's quality and safety or other operational issues, that changes happen by getting groups together, by having a culture of inclusion, having a culture where people can speak about what their opportunities are, and then creating a solution with metrics that is a system solution for addressing different problems. And I say if there's one point of this conversation about even how to integrate technology or innovation, it's to make sure that the underlying systems are really prioritized, that it's understood what the goals, objectives are, and then to pick the right tool for integration to accomplish a specific objective, not picking the tool because it's sort of cool or interesting in and of itself.
Yeah, so I think, you know, medicine has been transformed by becoming process-oriented, and maybe in the last 20 years or so. It's a lot more accurate, it's a lot more predictable, it's a lot more precise. So undoubtedly processes will have to be integrated even deeper in the field of medicine. However, I wonder sometimes whether sometimes our fascination for processes is overdone, where we begin to forget the human interface. And I have personally seen consultations where, you know, the EMR can sometimes become a bother. And I understand that in many countries, maybe in the United States, EMR has been earmarked as one of the reasons why there is physician burnout. So it's a system by which you're making the process better, getting the consultations on a digital format, making it accurate, making the data dredgeable, all that is good. But when the junior doctor forgets that the patient is more important than the desktop screen, and the patient begins to complain that he hasn't even looked at me, he hasn't heard my whole story because he's busy putting all the data in, then it begins to create patient dissatisfaction. And in our country, this is a feedback that we receive from especially junior doctors, that the doctor does not even look at you, he makes you sit on the side. I'm giving you one example of why processes, if they are not regulated, and that equation between people and processes are not defined for the healthcare system, it could go wrong. Again, I reiterate that there's no escape but to keep on refining the processes so that we become better and less prone to errors. However, the human interface as a clinician I feel is extremely important for this new patient who's seeing you as a stranger and has a lot to tell you. Some of it may be irrelevant to your consultation, but then that's the joy and beauty of a patient-doctor interaction, that holy space where he is putting his heart out to you and reaching out to you because he needs to be comforted, he needs to receive compassion. Somehow the process does not recognize that. That's the human element of it.
Thank you. Thank you both. I definitely resonate with your comment that a leader in healthcare or leadership in current healthcare systems need to be very careful how far they go with process improvement and process standardization. I am the one who does consulting, right? I am taking Mount Sinai teams to abroad, and we work with other hospitals and other teams abroad, and we try to teach them how to work under more precise, a more effective, a less wasteful processes, right? And when I go home, my wife, who's a primary care physician, or for that matter, a friend of mine who is a cardiologist, come to me, no, you cannot tell me how to do medicine, I'm a doctor, right? So there is this fine line between process improvement and keeping the physician in charge and keeping the physician's autonomy, making diagnostic and treatment decisions for the patient. It's sometimes tricky, so I thank you for that.
Can I mention a specific, because you asked for a couple of specifics. It's such an interesting point. I don't know how many of you saw the study that we'll talk a little bit about AI and where AI is real and where it's a lot of hand-waving, but where AI was thought in patient interactions to show more empathy than the actual physician, which I think in this example emphasizes some of the challenges we have with physicians, as we were saying earlier in the session, where you can spend several hours after your day just doing notes, which is, so the specific example I want to get to is some of the ambient listening technology, which is really amazing, and which has come to the point where there are a couple of different vendors that can just listen in a room and not just transcribe what happens in the room, but organize what happens in the room into a note that looks like a physician note, which is an incredible time saver, allowing for that time for the patient to actually just talk. And it is quite incredible for those of you who have seen it or who haven't seen it. So you can have a conversation, I had a nice trip to Bahrain, I did this, I did that.
And all of that's ignored, and it organizes a note that's really clinically relevant. At least it's really on its way. So that specific example, and since you asked for another kind of example, as we're looking at the tremendous margin pressures that we all face, different technologies and approaches that allow us to be more efficient. And I know we'll probably talk about that in the AI section, but there are very specific ways to integrate technology in service of solving a problem, which I think may be up next in your questions.
Yeah, no, I think that we can probably have this conversation as a free flow from now on, because we are touching base on everything under the same umbrella. So I guess that leads me to the natural question of what other areas you can think of where technology actually enables us to save money, improve processes, improve quality in healthcare, where technology is the main driving factor.
Okay, that's an excellent question, and I suppose it will follow the, I think it's called the Gartner's curve, where anything new is hyped a lot, and finally it finds its place after a certain period of time. I think AI is going through that phase. It's only 1 year and 6 months old, the newest form of it. And I'm sure it will get better and better as time goes by, no doubt about that. But as it stands, again, from the world that I come from, I've often thought about this as to, if today we were to draw up a policy, where would we place AI? I think if you look at a patient journey, from the time he develops his first symptom to follow up, it can be divided into 3 phases. The first is the pre-hospital or the pre-clinician or the pre-doctor phase, which starts with his first symptom, chest pain, and doesn't know what to do, middle of the night. He doesn't know who to contact. He may not even have a laptop, may not know which website. So he just does a frantic call to the neighbor, and the neighbor takes him somewhere else. And by the time he reaches the right person, a good 1 hour would have gone. I think AI can come in a huge way to enable and shorten that pre-hospital phase. If there are systems available that can shorten this time, it's chest pain, you have something that highlights this is your closest hospital, and this is the ambulance that takes you to the clinician's door, it can be life-saving. It can also give you, even without an emergency, all the information you want of the existing healthcare providers in your neighborhood, whatever it might be. It can give you general information about symptoms. All this it can do. The next phase is the actual clinician phase, and I'll come to that right at the end. Let's assume that the treatment is over and you're discharged from hospital. This is where AI can kick in a big way to manage the follow-up at home, organize the clinician visits, the physiotherapy visits, the nurses visit, advise on medications, the changes in dosages, provide a portal for the patient to interrogate the AI system for more information without having to take the trouble of going to the hospital every now and then. It can also advise you on lifestyle modification, what you must do, without having to fall back on the already overloaded hospital system. The middle phase, I believe, is different. And there are 2 areas in the middle phase. One is, as I mentioned, the doctor-clinician sanctum sanctorium, which should be left alone for the patient to create a bonding, for the doctor to create a rapport, and to get a differential diagnosis. There's no harm in having a differential diagnosis. That is the joy of medicine. It doesn't have to be accurate at first instance. That's the training. But you can fall back after he makes a diagnosis, use AI to make it precise. You could also shorten the throughput through the hospital by, suppose you order an MRI scan, to have AI-assisted teleradiology and telelaboratory and telepathology to shorten that time so that the treatment can be implemented straight away. So it actually shows a pan journey involvement of AI in its finest form, which may be a few years away, when there will be an active listening component, empathy, all those things that are not there now to kick in, so that the patient feels that his journey was worthwhile, state of the art. At the same time, most importantly, he received human care. That he had a human being who was involved right from the beginning to the end. And he leaves the hospital, comes back to the hospital with a smile on his face. I think this is where AI will perfect itself in due time. And not to forget, at least from the third world perspective, where out-of-pocket payment is for 70% of the people again, the cost must reduce itself. No technology is worth it if it's going to be unaffordable, and it is like that in India. Inaccessible, unaffordable, difficult to get. And I believe AI systems can come in to make it sweeter, easier, and cheaper.
And I agree. Look, we're a group of healthcare leaders and people deeply engaged here, colleagues from around the world. We have mission and we have margin responsibilities, right? And if you look on, and I suspect, I'm sure that AI will help with each of those. And the question is, where are we at this time for what's practical now, what could be helpful in the future? And I bucket it this way. There are the administrative aspects of what we do. There are clinical aspects of what we do and the research aspects. And where are we with each of these? And interestingly, so I would say that we may have, we talked about not being able to fill the amount of healthcare roles that we need. I would say that operationally, we may have 30 or 40% more people than we actually need, but we have so many systems that don't talk to each other, that we have to recreate work and the like, that it turns out that the first bucket and the one that is really active now is the administrative support that AI provides. Things like scheduling, something called active asset management, which my colleagues in Boston will be familiar with. The idea that we have an operating room, and Dr. Cosgrove mentioned this from Cleveland Clinic as well, that is a big both mission and margin driver in the United States. The idea that we don't maximally use those assets in the cancer care world, having patients wait to be scheduled for chemotherapy just because of inefficiencies in scheduling is really something that we can't tolerate anymore. And it turns out that actually there are viable AI solutions now to address some of these issues, which help us both with the healthcare workforce and also the cost aspects of things. But I will take a step back again, and when I advise different groups as you're around the world, the first question really is not what tool to use, but how do we create our structure, our, again, goals, objectives, and our metrics for success, and then bring in the tactics. So I just mentioned that what we're talking about now are very important tactics that are in service of a greater objective, whether that's quality and safety, whether that's margin generation or mission consistency. I think you have to evaluate each of those. And there are some in AI that are ready for prime time right now. And I can tell you that having brought in one company to this last health system was a $180 million within a year margin improvement. There's those sorts of opportunities right now.
Thank you both, Mark. I would like to steal one of your lines from the morning session that, and I transfer it to AI. AI is not shouldn't be a solution that is looking for a problem, but it is a solution that can be applied to actual problems. So what you just said reminded me of the clinical risk prediction. use of AI, and at our institution, actually, that is one of the key areas where AI is applied as a solution to a problem. And the problem is the waste of resources when we do not predict and do not know when a patient is going to be the outlier. To things like a patient fall in the hospital. Believe it or not, AI is being used very successfully to predict fall of a patient. And this saves many, many dollars to us, and this is one of the key solutions that AI can produce, give us. Going forward, I would like to ask what other, let me rephrase, what is AI today in healthcare? We understand what AI can be in 5, 10, 200 years from now. You read a lot of science fiction books and you can see where our world is going. We have movies about it. But what is AI today for healthcare, really? What is a proven solution? We talked about a lot of it right now, but I would like to just have a sort of a reality check where we are today.
So I think as Mark said, which is so true, that it can actually take away, it's already doing it, it's take away a lot of administrative burden. What you would spend hours on can now be, achieved in a few minutes. So it's definitely reduced the workload of medical administration. And that administration is a big word. It will go from accounting to systems to safety to maintenance to whatever. So that's one area where it has already made a huge difference. The other, which you have alluded to, is in the field of precision diagnosis. In radiology especially, imaging, it has helped doctors and medical providers to double the productivity, not with inaccuracy, but with more precision and more accurate, so that the turnover time has been reduced significantly. Pathology, a biopsy which could take 7 days has been significantly reduced with the use of AI. And I'm sure it will find more and more and more application in that segment of medicine which is, a little far away from that human interface. Yeah. That is where it has not yet come in, although there are models to show that, AI can teach you empathy and all that. I'm not so sure at this point in time, but I'm sure it will get better and better with. So, to cut the long story short, in medical administration, in streamlining processes, in helping the hospital governance system to get better, and in diagnostic imaging laboratory services, it has already made a huge difference.
If I may add one, thank you very much. It's a very good summary, but it reminded me something, that the benefit of telepathology, teleradiology, tele-patient monitoring, right? It's not only measured in cost or quality, which is our main theme, right? Improve quality, decrease cost, but also access. And that access is a critical element in many countries. In the United States as well, there are areas where patients don't have access to healthcare readily, like in New York or Baltimore or Cleveland, right? There are patients who need to have access, so these technologies enable that. One example is telepathology, not within the United States, but for example, we have established a link between the central hospital in Guyana with our pathology department. The machinery is available, the software is available to anyone. You can install it. I think it was a $2 million investment for the Guyana government. And now, instead of 2 months, the patient in Guyana waits 2-3 days for a pathology diagnosis. Now, this is what I call a life-changing or a system-changing investment, only $2 million, right? So I guess that technology is out there. sure, what I just mentioned is a niche technology, but still, I think there are many, many examples like that that can actually improve lives of many people.
You know, telepathology is a really interesting point. Until about 5 years ago, the bandwidth that was required to, remember, pathology as a slide has a 3D requirement to be able to really transmit enough data. So unlike radiology, which has been going on for a long time, our ability to really share pathology has really only recently been improved. So we likewise built a program in China and built, interestingly, a radiotherapy unit. It could run from Boston the entire rad-onc machinery in Bermuda, for example. But what I found probably most interesting, that even within the United States, of the patients who came to be treated at the Brigham Dana-Farber Cancer Center, about 15 to 20% of the patients came with the wrong diagnosis from within the United States, just because of the specialty capacities of those who do certain things all of the time. So we often talk about improving access in low resource environments, when in fact, even I think in all of our societies, that there's a concentrated area with knowledge where these technologies are super useful. The other thing I would mention, I have to get back to your comment about science fiction in the movies, because obviously I was sort of addicted to that as a kid, which is how I wound up in Johnson Space Center for a couple of years. And it is frightening, and one of the things that we have to really spend a significant amount of time on is the regulation and thinking about this. Remember, for those of you who are old enough to the old Star Wars and Star Trek, where they had the flip phone and talking to a computer, it seemed as crazy as ever and impossible. And some of the other science fiction films, I've just been impressed with how these thinkers come up with the possibilities for the future. And some of those possibilities are pretty frightening. So I think it's our responsibility as leaders to really take those regulatory issues seriously as well.
Well, thank you. I was given the sign that we are actually running out of time. So do we have possibility for questions? Or we should close? 5 minutes? Okay. So we have 5 minutes for questions. Anyone? Wait for the microphone, please. I'm sorry, we don't hear you, so please use the microphone.
Sorry, I do apologize. I'm talking about the accountability for the accuracy of AI diagnosis. That's what I'm talking about.
Yeah.
We could have it in the individual cases. We could always have accountability of somebody else doing a discussion.
May I take
in the AI, what the situation is now.
Right. So let me take a disclaimer before I let you respond. So I don't think that anyone on this panel believes in AI diagnosing. We believe AI supporting diagnosis by a physician.
One of my favorite analogies comes from the legal world, where somebody used ChatGPT and other AI technologies to inform a brief. And AI has a possibility to make up things still. And we don't fully understand all the neural networks that, simulated neural networks that come up with things. So I think I agree, we have some distance before we're going to have absolute belief in the clinical realm that I think it is supporting in things like radiology and the like. But I don't think anybody would trust it to really make diagnosis and treatment decisions now.
Yeah, thank you to all the panelists. I'm Dr. John Stapert, and most of my life, working life, is as a clinical psychologist. So I really appreciate your emphasis on the relationship between the physician and the patient and that contact. What I'm wondering is whether we have or know how to teach in med schools the physician side of that patient contact, because if that's going to make a critical difference, and of course I believe it does, how do we train it, how do we measure it, and know it's going well?
I've been in a teaching institution for quite some time, and I want to put this in the context of where we are today. There's lots of articles from Indian AI experts saying that it's time medical students, that's the undergraduate students, must now have AI incorporated in their training. I must disagree, because I feel that the essence of being a physician comes from those difficult years, the mystery that is there in the human body, human illness, human pathology, and the nuances of how a clinical diagnosis is made. Ultimately, we want the accurate diagnosis, no doubt about that. But I think it comes from those long years of training, the grand rounds, the firing that you get from your clinical professors. You see them examine, you see empathy which gets indoctrinated into you. Today, as it stands, it may change. Today, as we stand, if we remove that element and say AI will come in, I think it's going to program the future medical students, the future doctors differently. Because their sense is that it's taking away the need to explore, to research, because it's already made. That said, I strongly believe that for postgraduates, AI must be a part of their curriculum. Because as they train to be specialists and super specialists and advanced trainees, there is no running away from the fact that healthcare of tomorrow is going to be significantly impacted by technology, and you must be tech savvy. By which time, as a postgraduate, you already have got a good clinical foundation, apart from the essential training of empathy, compassion, values that your teachers have given you. If that is disrupted, then I think we will become machines. That's my belief, that's my opinion, but it may change as AI gets better in the future. I don't know whether I've answered that.
I would just comment, I agree that for now, I think what we can expect is if we can remove some of the administrative, non-doctor tasks from the doctor to free up time, it's probably the best we can hope for right now in the short term.
Well, if there is no other question, then I would like to thank you, my fellow panelists, and thank you for the audience for staying with us.
Thank you so much. That was really very interesting, and I think it's opened the door for a lot of questions. And I think I do agree that AI or technology or any innovation should be used to solve a very clear and existing problem and not to create more problems. And I think we do all agree to keep the human touch. So it's not replacing us as healthcare workers. It's just helping us to really get the outcome we are looking for. So thank you so much. So I think we have some technical issue, but I think we are moving to the next exciting session, fireside chat under the title of Evolution of Healthcare Delivery, the Role and the Impact. And we have, we are honored to have again Dr. Man Faris and Dr. Toby Cosgrove from Cleveland Clinic. So please go ahead.
So thank you very much. Thank you for the nice introduction. And once again, thank you for having us in Manama, Bahrain. This is my first time. My name is Man Faris. I do speak Arabic, by the way, and I'm a cardiologist at the Cleveland Clinic. Hence, I've been practicing, next to Toby for the last 25 plus years. And I also have a role in global patient services at the Cleveland Clinic. This says 15 minutes, by the way, is okay, so we have a little more than that. With me today is Toby Cosgrove, former CEO of the Cleveland Clinic, And really, I introduced them earlier this morning, and all of you was here. And I'm glad that many of you stayed around for the afternoon session postprandially. It's difficult, especially if you're jet lagged like some of us. So if the interview is a little clunky, you know, feel free to pitch in, as you can, Toby. I'm going to start by asking Toby a very simple question. You know, you're kind of like LeBron James. Toby, you know, you perfected your skills, and you keep going. You know, so what is it about you? You know, where's the energy coming from? At age 39, you still play, and you score about 25 points a game, and you have double doubles and all of that. Tell me more about that.
Right. Well. So can I ignore that question? And I'd like to say that, I sort of raised the issue of AI this morning. Let me just say that certainly I don't think that AI or LLMs are ready for decision making, but think about what they can do for cost and efficiency and productivity. For example, Cleveland Clinic has 3,000 people who work in revenue cycle, 1,000 people answering the telephone, 700 people who do coding of charts. All of that ought to be able to be automated and decrease the cost and improve the efficiency. So I am completely agreeing, but I don't think we've heard the last as far as being a serious aid to physicians in terms of decision making in the future, but not yet.
So now we learn that Toby only is turning into a politician. He hears a question and he answers something else that he has in mind.
That's as a politician.
As a politician would do. So now, seriously, your energy, where does it come from?
I think I'm chronically dissatisfied, and then I think it's interesting to try and be looking for something better all the time.
Many of us heard you talk about dyslexia early in your life. Can you talk a little bit about this challenge, and what advice do you give to families when they face this with their children?
Well, it turns out that I am probably one of the worst students of all time. I got into one of 13 medical schools I applied to. I was told not to go into cardiac surgery because I didn't have it. I didn't find out that I was dyslexic until I was 34 years old. But I have subsequently been able to be introduced to some of the people who really study dyslexia. And I think it is a challenge for people who are trying to get through their academic careers. But I look at it as a blessing when you get out to the world, because you think differently about problems than most people do. And you frequently come up with different solutions. So I look at it as an advantage, but it certainly is difficult to get through the academics at an early age.
It's remarkable, and this speaks about your transparency, which takes me to the next question. You take me back to the time when you decided to publish the outcomes from cardiac surgery at the Cleveland Clinic, and how was that received where did the idea come from? What was the need? How was it received by your colleagues, and more importantly, how was it received by your colleagues outside of the Cleveland Clinic?
So the story is interesting that when I joined the Cleveland Clinic, they were starting a series of recording everything that happened and everybody who got cardiac surgery and following them up, starting in 1972. And turns out that we learned an enormous amount from that. It changed the practice of cardiac surgery all over the world, and some of the things that we learned. And so I thought that it was only fair that we as cardiac surgeons reported to the cardiologists what our mortality rate was and how successful we were being or how successful we weren't being. So starting about 30 years ago when I became head of cardiology, every year we would have a joint meeting with cardiologists and somebody would stand up and give the report on coronaries and valves and aneurysms, etc. And the cardiologist would ask us for the slides and we'd give them the slides, and then I thought, well, we ought to put this in a booklet, and so we put it in a booklet and gave it to the cardiologist, and then I said, what the hell? Let's put it out and give it out there in the world. And it turns out that there are only 2 institutions around the world that did the same sort of thing. So basically that made me come to the conclusion that radical transparency was our obligation, both from looking internally at the results we got internally, and we looked at surgeon by results, etc., and then transparency to the outside world, because in fact we were a community resource. So then when I thought that went fairly well, and I thought, I don't think you can really understand the problems and the potential solutions to the problems unless you look at them on a regular basis and analyze them. So then I asked every department in the Cleveland Clinic to do that same sort of thing, which is continued, and you can go to the internet now and look up what various departments' results are. Just to show you what the results of that sort of scrutiny on detail, and we started in 1972, and every year we would look at what were the risk factors for cardiac surgery. And year after year after year, we looked at it and we found first it was the age, and then it was the number of vessels, and then how sick you were, whether you're male or female. It changed over time. Eventually it got to the point where, and we would work on each one of these, eventually it got to the point where whether you'd had a blood transfusion or not was the major risk factor of whether you'd survived. And so all this time, the mortality rate was gradually coming down from 1.5% to 1%, etc. In coronary bypass surgery last year, the mortality rate for over 1,000 cases was 0. And that's just the fact that you have to look at the results analytically with data in order to continue to improve. And so, you know, it's been difficult, it's been expensive to do. It hasn't been met with huge applause and enthusiasm from everybody in the institution, but actually it's the only way you can get better.
So that set the standard, but back the issue of applause and enthusiasm, was there any external backlash as well?
Interestingly, some people looked at it as advertising. Interesting, Brigham and Women's Hospital did the same in cardiac surgery. The biggest hospital in China did that same for their cardiac surgery. It's best I know, nobody else has done that.
It's interesting what you just brought up, because we did the same thing with machine learning in looking at the risk of cardiac consequences or side effects from liver transplant patients. And it was only when we used machine learning that we kind of re-looked at the risk factors, and we learned a lot, but it turns out it was intuitive. If you're old and you get a liver transplant, you're more likely to get cardiac consequences, you know. So it's, AI seems to be the theme today.
Well, interesting, just on that aspect from machine learning, you can now look at an EKG and predict when someone's going to go into atrial fibrillation in the next 6 months.
That is, yep. All right, let's move a little bit towards your role, or before we move to the role as a CEO, what do you think the biggest risk for cardiac surgeons going forward? You know, we cardiologists are starting to swim in your swim lane a little bit with TAVR and some of the procedures. What advice do you give to the future cardiac surgeon?
Interestingly, I think that if you look at the evolution of the treatment of any disease, It starts out, interestingly, with surgery. Look at tuberculosis. It started out operating on tuberculosis, then along came drugs, and then came prevention. You look at coronary artery disease. It started out with cardiac surgery, then it's interventional stents, and now it's lipid-lowering drugs. And then it's prevention. So I think the natural history of almost any disease is that it starts with a surgical procedure, then a less invasive procedure, and then a prevention. And so let's look at cardiac surgery. Cardiac surgeons started out doing valves, then they did coronaries, and then they did heart failure, and then they did transplants. I don't think there's going to be any shortage for cardiac surgeons to do things in the future. We'll just change what we spend our time doing.
That's great. So we get a little more refined with time. You know, we start with surgery and we get a little more refined. Your role as a CEO, you had no training, no education. You walked in and you're responsible for how many thousand employees at the time or caregivers? And 40,000. And what type of training did you find most desired or wish you had? And what advice do you give to the next people in that role?
I was totally unprepared to be a CEO. In fact, I hate to tell you this, but I didn't even know, you know those parentheses on P&Ls? I didn't know those were bad. That's how naive I was. But fortunately, I had a lot of great mentors that helped me along the way. Michael Porter at the Harvard Business School, Jack Welch at GE, several of his associates at GE. It took me under their wing and gave me little pieces of advice along the way. And I read incessantly about leadership. As a result, I felt that we don't do a very good job in teaching people about leadership in healthcare. We generally select our leadership on the basis of how much they've written, whether they're good gastroenterologists or not, which basically has nothing to do with leadership. They may be, and we're all trained to be technicians. We're not trained about leadership. Interestingly, the higher up you go in an organization in terms of leadership, the more important emotional intelligence is. And you see this repeatedly over time. And so we started out by deciding that we would try and do better about selecting and training leaders. Gradually we put doctors in leadership positions and eventually had about 250 doctors in various leadership positions. And then we would send the most promising of those off to get an MBA degree in many cases. And just to give you an example now, 6 of my former executives are now CEOs of hospitals. My successor was a cardiac surgeon. He decided he wanted to be more of an administrator. We sent him to get an executive MBA at Harvard. Then we went to Abu Dhabi as chief of staff, then CEO, and now he is my successor. He's smarter, better trained, better looking, and nicer than I am.
Do you still believe in physician leadership, for a healthcare organization?
Yeah, absolutely. I believe in physician leadership. You know, it's easier to teach a doctor business than it is to teach a businessman medicine. And the basic thing that we do is look after people, and that has to be front and center, not the bottom line. And if you do a good job taking care of people, eventually you can get people to help you with the business.
You mentioned emotional intelligence. Is this innate or is this learned?
Okay, I have to tell you, this is probably the most embarrassing story that ever happened to me. So I was, part of my learning as I found out I was going to be CEO, I called up Michael at Harvard Business School, Michael Porter, and said, help, what's a CEO do? And he said, well, come on up. So I go up to Harvard in my little blue suit, never having crossed the threshold of a business school before. And I went into his office, and he shut the door and started grilling me for 2 hours, taking notes like crazy. It turns out he was writing a book on healthcare. And I was feeding his book. And out of that, he helped me along the way as I tried to help him. And he wrote case studies on the Cleveland Clinic. So the first time they presented it at the class, I go up to Harvard, and I don't know if any of you have ever been in a business school before, that they seem to have these horseshoe-shaped auditoriums. And the students got the study, bing, 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 like that. And then I was supposed to go up and answer questions. And very nervous, I'm about halfway through. And a girl on the left-hand side in the second row raises her hand and says, Dr. Cosgrove, my father had mitral valve prolapse. And we know that you've done more of those operations than anybody else in the country. But Dr. Cosgrove, we decided not to come to you because we heard you don't have empathy. Dr. Cosgrove, do you teach empathy? I don't know, I have any idea what I said after that. But it turns out that what it made me do, and subsequently I was in Saudi Arabia, and they're dedicating a new hospital, and the CEO of the hospital says, and this hospital is dedicated to the body and the spirit and the soul of the patient. And I'm going, yada, yada, yada. And I look over, and the king and the crown prince are there, and they're both weeping. Tears are coming right down their cheeks, and I'm saying, oh my God, Toby, you really missed something. So I have to look back over my career, and I'd become a technician, a pretty good cardiac technician, and after a lot of work at doing that, but I hadn't spent a lot of time with the patients, so I figured, okay, what do patients want when they come to the hospital? They want three things. They want a great clinical experience, and that's what we'd spend all our time on, measuring and recording and getting better and better. They want a physical experience, and they want an emotional experience. So the physical experience, we started working on cleaning up the hospital, looking at the architecture, hiding all the stuff, getting the stuff out of the corridors. You saw all that. We even painted the hospital white.
I was going to say, you know, we can choose any color in the hospital as long as it's white, you know, exactly. This legacy goes on right now. So we have everything. Even my house is white now.
The third thing they wanted was empathy and an emotional experience. So we took all of we decided, how are we going to teach this to an organization? And so we took all 40,000 employees, and we took a half a day and put them on tables like here, and mixed them up, doctors and janitors and bus drivers and nurses, and we talked about the Cleveland Clinic experience. When they came out of that, everybody got a button that said, I'm a caregiver. And we tell everybody in the Cleveland Clinic is referred to as a caregiver. And so what we saw from that was the patient experience went up like crazy, the employee engagement went up like crazy, and we went from about last as far as patient experience is concerned to one of the top in the country, just on all these sort of things. And one of the things that came out of that was a video that I'd like to share with you about empathy. So
we have the video, actually. It's about 4 minutes, so it's an intermission.
By the way, there's no sound other than music.
this never gets old, by the way. You know, we watch it, and I've been looking at people. Nobody fell asleep.
Yeah, the first time I saw that, I was sitting in my office and watching it with the tears rolling down my face. Generally, we serve this with Kleenex.
Yeah. I have few more things. I hope we're doing fine on time. I have a few more things to touch on. The institute model, a merger of clinicians and surgeons under one roof, which seems implausible or impossible. Where did you come up with the idea, and how did it go? How was it received?
Well, it turns out that you and I used to share a common waiting room, and the cardiologists were on one side and the surgeons were on the other side, and I'd go back and forth, and they'd come to the operating room, and yet you were in the Department of Medicine and I was in the Department of Surgery with gynecologists and neurosurgeons, sharing nothing with them except we wore gloves most of the time. So, you know, I thought, you know, that's an organization that is built around the guild system of doctors. It's not about built around patients and patients' problems. So what we did is we decided, okay, we're going to reorganize ourselves around the patient problems. And so we put the cardiologists and the cardiac surgeons and the vascular surgeons in the Heart and Vascular Institute. We put the neurosurgeons and the psychiatrists and the neurologists in the Neurologic Institute. We put the nephrologists and the urologists in the Urologic Institute. So this was the first time that a hospital had ever been organized around patient problems rather than doctors' guild system. And I think it did a couple of things because innovation happens when different disciplines come together to solve a problem. And it happens around the coffee pot or a common patient who has got a problem you don't know how to solve. What are you going to do for Mrs. Brown? I don't know. But let's try something, and you work together, and a new solution comes out of it. And so I thought putting them physically together and intellectually together would do better for patients, and it would do better in terms of the quality of care and the innovation that came with it. And, you know, interestingly, you know, I had about 2,000 vice presidents who all thought they could do the job better than I could. But nobody came to me and said, that's a terrible idea. And subsequently, people never came to me and said, that didn't work, we got to go back. Is that fair?
It is absolutely fair. As a matter of fact, I think there was a perception that this is the surgeon's way of dominating the healthcare system. But it did really not pan out to be. I mean, the system has been working fine for us now for almost a couple of decades, correct? I'm going to switch gears a little bit and talk about strategy and business strategy in particular. Take us to your decision about going to the Middle East, and what were the risks, and what did you see as a potential reward? You mentioned earlier in some private conversations that this is not about the finances. It's not necessarily a financial endeavor for the Cleveland Clinic, and it carried some risks. So please take it from your end.
So the Cleveland Clinic had a long history with patients from the Middle East after we operated on the heart of the King of Saudi Arabia. He was Crown Prince. We operated on him, and he became king. We did a multivariate analysis, and that hasn't turned out to be true for most of the people we operated on. But anyhow, and so we had a lot of patients come to us, and we do about 30 heart operations a month from people coming from the Middle East. 9/11 came along, and it stopped immediately. A, they couldn't come. B, they didn't want to come. So my predecessor said, let's go and we'll meet them in London. So we went and looked at a hospital in London, and that didn't turn out. And then, as fortune would have it, the founder of the UAE, Sheikh Khalifa, came to the Cleveland Clinic for a kidney transplant.
Sheikh Zayed.
I'm sorry, Sheikh Zayed. So it turned out that he had a long, complicated history with that kidney transplant, and they were there, the entire government of the UAE was there for 6 months. And they then subsequently they came to us and asked us if we would build a hospital in Abu Dhabi. And they wanted a Cleveland Clinic hospital with a Cleveland Clinic quality experience, etc. So we made a deal with them that they would build a hospital, they would pay the salaries, and they'd pay us a modest management fee. And frankly, it took almost 10 years to build a hospital. Enormous amount of our time, effort, and intellectual capital went into that. My biggest concern was where are we going to get the doctors? Turns out that there were 10,000 doctors that applied for privileges. We hired 250. 80% came from the United States and 20% from England, or from Europe. And the quality, so my fears were alleviated. Now, let's go back to what my thoughts were. It turns out that almost every American global major business is international. Whether it's manufacturing cars or oil companies or IBM or any of the healthcare providers are international, and healthcare has not been. And this was the first time an American hospital had gone full tilt overseas, and so I thought, what do people come to the United States? What do they want from the United States? They want about 5 things. They don't want our steel, or particularly our cars. They want our innovation. They want our graduate education. They want our entertainment. And they want our health care. So this, I thought, was an opportunity. We started out, the first time we did it was in Canada in a limited way, and then Abu Dhabi came along. And subsequently, after what we learned in Abu Dhabi about both the difficulty and the opportunities to do things internationally, we established a hospital in London, which opened about 2 years ago.
That's wonderful. So I'm going to have some, confessions to you. Some of the people that reported to you asked me, in my capacity, Global Patient Services, whether the hospital in Abu Dhabi will be taking patients from them, siphoning patients that were coming to Cleveland. And what we have found is that our numbers grew from the Middle East and including from the UAE. So the brand recognition has been very helpful to us in Cleveland. So there was really no challenge from that perspective. Now, in my capacity, I find that calculating the cost and estimating the cost for healthcare on the US-based standards to international markets is incomprehensible, which led me to looking a little bit deeper within our system to calculate the cost, and I can't find the cost. You served as a CEO from 2004 to 2017. If you asked your deputies to calculate the cost of a particular procedure, did you get the confidence that they were giving you the right numbers, or how was that? How was the sauce made?
We have not done well in understanding cost, and I don't think we're any different than any other hospital. We essentially try to balance what the government pays us for health care, which is about 85% of the cost of actually delivering the care, to what insurance companies do, and it's a cost shifting between those two. And it is a negotiation always with the providers and a fixed fee for coming from the government. So this has been a very murky area for us to try and figure out exactly what our costs are along the way. Even if you wound up doing it on an hour-by-hour basis. I mean, how much is a nurse's, let's look at cost in terms of nursing. If you use half an hour of a nurse's time and she gets paid X number of dollars, you could assign so much of that to the cost of healthcare. We don't come close to doing any of that. And I don't think any other hospital really does either. So there's a tremendous amount that we could do to understand our costs better and to reduce them substantially. You know, I use I mean, just going back to this AI thing we talked about earlier, Cleveland Clinic has 1,000 people who answer the telephone call centers. That ought to be automated. We have 3,000 people that put out a bill. That ought to be automated. I mean, my gosh, the cost, the administrative cost and not to mention the repetitive work that everybody does, the caregivers do, we ought to mobilize that. Technology to replace labor.
I think I'm going to dedicate the rest of my career to this particular problem. Earlier today, an analogy came about airline industry and healthcare. I believe in that analogy, by the way, and I still think that healthcare is as safe as the airline industry. It's going through a hiccup right now. The other industry that I personally refer to, and I don't know if you agree, is the banking industry. You know, people want accuracy, want to. So the airline industry is seeing some hiccups right now because of lack of self-governance, lack of quality control, or maybe some lax attitude. Do you see this as a risk for the U.S. healthcare system?
Well, I think there is human, was referred to earlier as bringing the issue of quality in healthcare to the fore, and I think we've come a long way since that time. Certainly the clinic has put increased emphasis on quality and measuring quality and looking for quality and complications. So we're a long ways from being perfect, but we're on a journey.
I don't know how we're doing with time, Ransel. I'm depending on you, another 5 minutes. Great. Take us to the White House. You've been invited twice to be Secretary of Veterans Affairs. And I'll tell you, amongst the rank and file at the Cleveland Clinic, there was a little bit of a skipped heartbeat in my analogy when you were offered and people thought that you were on your way out. And you're an Air Force officer and the Commander-in-Chief called you. What happened?
Well, to give you a little bit of background, I was in Vietnam and I was in charge of evacuating the casualties from the northern half of the country. And during that time, I took care of 22,000 sick and wounded GIs. So I had some empathy for the veterans. There was a crisis in the VA system, and by the way, the VA system has 160 hospitals and 360,000 employees. So it's a very big system. They had a crisis of waiting list, and they fired the Secretary of the VA under Obama's administration, and I was asked to take the job. And it turns out that there were 18 months left in that administration. And having tried to bring a change in the culture of the Cleveland Clinic from being a doctor-centric place to a patient-centric place, took about 5 years, I think, too. So I realized that changing a culture of a huge organization took a long time to do, and I didn't think I could make a difference in 18 months. I was then asked if I would be on a commission to study the VA, so I spent 9 months going from Cleveland to Washington back and forth to learn about the VA, and I learned about some very significant things that I thought were issues with the VA, including the fact that they had 120 versions of the electronic medical record. They didn't have a common purchasing. There were a number of issues, and plus waiting lists were difficult. And I thought that there needed to be significant structural changes in the veterans program. And when President Trump, President-elect Trump asked me if I would take the job, I started calling senators and representatives who sat on the various committees, asking them, finding out their appetite for change in the VA. And there was no appetite for change in the VA. So I turned them down for that reason.
Thank you for the insight. This is the first time I hear about it. You know, Frank Sinatra had a few regrets. What are yours? What did you want? Well, let's keep it open.
I regret that I didn't move fast enough. I regret that I was not better prepared for the job. I made a lot of mistakes along the way. Most of them were not fatal mistakes. You know, I think the only thing that you regret is you didn't move fast enough. You weren't. I don't regret that I didn't work hard enough at it. I worked as hard as I possibly could at it. I do regret that I didn't make the decisions about personnel, etc., as fast as I should have.
This is a man that asks us to see patients on the same day. He's talking about not moving fast enough. You moved very fast. You know, I think you moved faster than most of us could handle. Just in terms of disclosure, 80% of what we just talked about was not shared with Toby, so it was just all improvised. And I hope I gave you a little bit of a glimpse towards the visionary person that he has been at our organization, taking the organization from one stratosphere to many levels higher, and we still live with this legacy. So thank you very much for your candid responses today. I personally enjoyed it.
I have one request.
Go ahead.
Dr. Toby, could you please get everybody? Could you please give everybody that wonderful fact of how Cleveland Clinic grew from the time that you came in from one hospital to, I guess, 20 doctors to where it is? Could you just repeat that? I found that so fascinating, and great credit to you moving very fast.
I arrived at the Cleveland Clinic in 1975, and it was one hospital and 200 doctors. It is now 23 hospitals, 81,000 employees on 3 continents, and slowly getting better. Thank you for the opportunity.
Thank you so much for this inspiring session and discussion. And really, we enjoyed it and we learned a lot of lessons learned there. Thank you so much. And we'll move to the next session, and I think this topic is very interesting to a lot of us. Security in protecting the healthcare system. So we're welcoming back Dr. Mark Davis, who will be the moderator of this session. And the panelists will be Mr. Issam Al-Gubaisi, I think I'm pronouncing the name right here, who is the CEO of the Business Intelligence Group from Kingdom of Saudi Arabia. And we have Mr. Leo Lislan, Director of IT from American Mission Hospital. And Mr. Hamad Abdurrahman, who is the Director of ICT from King Hamad University Hospital. So please join us on the stage.
Well, that is a very difficult act to follow. I will have, I hope, the emotional intelligence to suggest for all of us how inspiring that is. For those of us in healthcare, true north, patient-centered approach, and I think really one of the leaders to help us really understand that globally. So, quite a session. So we'll switch gears a bit to talk about something a little bit more in the weeds, which is cybersecurity. And again, thanks to Ransel and C3 for bringing us together. We have really a distinguished panel here. And we spoke a bit about my personal experiences in the past. One of those that seems like a black box to many of us, though we know that there's a risk, is that of cybersecurity. We've seen many issues with loss of large amounts of personal data, interference with financial and other patient care systems, with ransoms that have been requested and paid, and still loss of data. We have the often unspoken but no less terrifying situation with what we call the Internet of Things, the idea that we implant devices, we do all sorts of things that have technology and other connections. And as we've learned a great deal from outside of healthcare about cybersecurity risks, we have a terrific panel here to help us understand how we should be looking at this now. So what I'm going to do is ask our panelists, we'll just go down the line here if we could, to introduce yourselves and your backgrounds, please.
Thank you for having me here today. I'm Issam Al-Gubaisi, CEO of Business Intelligence Group. When we talk about the healthcare sector, particularly vulnerable to cybersecurity, risk and stakes for patient care and safety are particularly high. Healthcare facilities are attractive target for cyber criminals in light of their size. Technological demands sensitive data and unique vulnerability to disruption. The combination of power cybersecurity practices sensitive data storage and distribution to preserve business continuity at all costs. Makes the healthcare industry prime target for the cyber criminals and inevitability that was further exacerbated by the pandemic. To support the reference of healthcare cybersecurity program within the current cyber attack climate, I will tell you the biggest cyber security challenge in the healthcare industry. This cyber threats pose the highest risk to patient information and healthcare data security. That is phishing. When we talk about the phishing is the most prevalent cybersecurity threat in healthcare. Phishing is the practice of the infecting assembly an accused email with the malicious link. Because most cybercrime begins with the phishing attack, and phishing has one of the highest financial impacts on an organization. Phishing defense should be referenced in healthcare information security initiative.
Yeah. Thank you. And could you just again introduce yourself and your background and?
Okay. I'm Isam Al-Qubaisi. I'm from Saudi Arabia. I'm CEO of Business Intelligence Group. I'm cybersecurity in Saudi Arabia. Yeah, and working with the government in the different sector.
Terrific. Thank you.
You're welcome.
Please.
Thank you. My name is Leo. I'm the head of IT in American Mission Hospital for the last 11 years. I'm in Bahrain for 25 years. Yes. Thank you.
Thank you. Please.
Thank you. Good afternoon, everyone. My name is Hamad Abdurrahman. I'm the director of IT in King Hamad University Hospital. I've been doing IT for the past 20 years, 10 of those purely focusing on cybersecurity. Although I'm quite new to the healthcare sector, I've been doing it for the past 5 years. I can see a lot of challenges and variation from different fields. I've been working in the aviation field and the consultation field. So, as you mentioned previously, IoT is quite adamant in healthcare. Now we see a trend in cybersecurity that's more focused on MIoT, which is medical IoT, and does have a lot of challenges. We can discuss it later in this panel.
So why don't we pick up on that background, which I always find interesting, to be able to take the lessons learned from outside, and how do you look at that background that you brought with you from another environment? How do you compare it to what's going on in healthcare, and what are the threats? Are they similar? Are they different?
They're quite different. They're quite different. Most cybersecurity, say, programs are focused on external threats, right? But in the medical field, you open your doors to everybody to come into the hospital. So that opens another aspect, which is the physical security. So you might be having attackers that, let's just say, that are planning to attack your systems. Instead of doing it online, they can come into the hospital themselves and try to do it internally without you knowing. So the attack surface is quite bigger there. That's one aspect. The other aspect, I'm sure my colleagues who are more diverse in the medical field know that healthcare systems are quite outdated with regards to cybersecurity. You have a lot of legacy systems. So you have to work around that through applying cybersecurity, say, precautions, but at the same time cater to that legacy, I would say, stagnation to stay in such old tested environments rather than pushing for an upgrade. So you have things that are overlap that legacy system, say virtual patching, virtual firewalls, that encapsulate that legacy systems in a security environment and ensures that they are not, say, deducted to any attacks or threats that are out there. So it's quite different. It's been, I mean, I took the right decision to go in healthcare. That's not only from an empathy perspective, but also I learned a lot through how to tackle such challenges.
Thank you. And Mr. Lesson, how do you approach security for our systems in the face of such rapidly changing technologies? What's your approach?
It's actually interesting to see in the entire session, you can see the CEOs and doctors are all talking about AI and technology. Whereas 10 years or 15 years ago, it is like a Chinese word or something which is unusual for leaders to hear from the IT perspective. We being in the IT, hearing this particular session from various leaders, it is encouraging for us. For example, if I go to a CEO or a leader saying that, we have to do a VAPT, he'll be asking, what the heck is that? I mean, what are you talking about VAPT? So that actually gives us an encouraging factor that we can approach and get things done. Because in a healthcare environment, it's not an IT industry, where a healthcare environment, the investment more on the healthcare side, not on the technology side. Because they look at it in an aspect of, how do we make money or revenue out of this? So you buy an MRI, yeah, you get a revenue out of it. You buy a technology, what revenue you bring in. So the trend towards the AI and the technology involvement, which gives and highlight that there is an indirect cost, it comes. But every organization has to start somewhere. So you start off with the EDR, endpoint detection and response, network detection and response, then you go into an AI-based cybersecurity appliance. So it is a strategy, it's a comprehensive strategy should be in place in every organization. So when you talk about cybersecurity, it's not just one particular product or an appliance you brought in and then it satisfies the complete organization or secures your organization. Whereas it's a journey for years that you start off with something and then you evolve and then you achieve something. And yet no one can say that, we are 100% secure, guaranteed that no attack can come in. We are always vulnerable. The threat is always a formula of a vulnerability and an exposure. So how vulnerable you are. So you need to look at your own organization. What are the products and what are the security measures you have taken, and making sure that you are closing all the doors. So as Ahmed said that we are open to the network. I mean, a lot of patients are coming in, a lot of users are there. They're all accessing the internet, and some people say that once you move into the cloud, you are more secure. But it is not. In reality, it is not. Because you have a cloud security to be in place and you are accessing the cloud system from your network. There is a greater chance that there is a DDoS attack and then the complete network comes to standstill. How do you mitigate that? When you look at the AR, augmented reality and virtual reality and AI, all this combined together, and which is newer technologies on board. Now, robotic surgery is also using the augmented reality, where you have the Apple Vision Pro, which is also using the augmented reality. Now, when you have a robotic surgery, which is the base foundation or the platform is 5G, which is a fast internet speed where somebody is operating from remote and it is used as the internet. But how do you mitigate if the internet goes down? So, technology is evolving, inspiring, and there is no doubt that technology is revolutioning the world. But at the same time, the threat is also following along with the technology. So we have to be careful in terms of going ahead with the technology. We also have to take care, what is the measures, how do you mitigate when there is things go down. So that's very, very important for any organization.
Terrific. Let me move to sort of a case study question. So many of our audience here are either involved with building new programs or expanding programs, and some of us have had the experience of saying we'd like to do this or that, and then speaking with our IT colleagues who say, no, you can't do this or that, or it's going to be a long time before you can do this or that. So tell us your thinking and mindset that we're going to start a new cancer service line. We're going to put a new proton therapy unit in our system, and we're going to be able to let patients directly schedule. The doctors are going to use ambient listening in their records. I'm just trying to paint a picture. What goes through your mind as you think about how to address this from a cybersecurity perspective? And whoever would like to jump in first.
As I said, Mark, you go into a AI-based technology where there's no human intervention required. Now, for example, when you have an appliance of AI-based, it automatically senses that whether you are accessing certain system unusual. For example, I open a particular server which I have not opened for last 6 months, let's say. And it analyzes that, it analyzes a pattern. It's a pattern analysis. And it senses that you're using this particular server or particular PC, particular equipment. After a very long period of time, it blocks you. It isolates you. So when it is attacked, it isolates you from the network. So this is one of the things which every organization should think of having it. And at the same time, as a very traditional method, we call it as a VLAN. We isolate the networks for a medical equipment. And there are various methods to mitigate certain cybersecurity angle perspective. Yeah.
If you allowed me, Mark, also, as you know, after pandemic, everything is different. The leaders, it's belief that technology is free on board, and they are used different programs in the hospital. As Mr. Liu see, the records is free on board to make the good decision. So when the doctors use this data, should be healthy data. Usually when use this data, it will be like the dirty data. It's not help the doctors for make the decision. And today, after the pandemic, the cybersecurity department, it's very, very important in all of the organization. Before the pandemic, it was when you talk with somebody about the technology, they said it's okay for any sector, but in the healthcare we can't do it because we are communicate with the humanity. But now they are believe that this technology it will help us. And when you have the big data in the different country or different, you should have the strong cybersecurity department.
Thank you. Please.
I'd like to iterate from the technical terms. Like everything comes to management, right? If you have a proper management framework in place or a proper cybersecurity program in place in the organization, any system that comes in has to go through that program. So let's start with your case study just now. So I will look into 6 aspects. Basically the network side of things, the hardware side of things, the system side of things, data, users, and applications. That's the structure that I would work with to ensure something called in cybersecurity terms, which is zero trust network. Don't trust anything. Make sure that systems that shouldn't talk to each other don't talk to each other. Make sure that people shouldn't talk to each other don't talk to each other. So if there's a security breach, that mitigates it to a very limited systems, people, or applications, or data, or a bundle of all that 6. Once you have that, that's the first thing that comes into place. And of course, you have the cost to benefit ratio. So if I am going to apply certain application, a certain system, a certain program, whatever it is, I have to make sure that the cost of this has to be quite close to the benefit, that it doesn't exceed it, maybe even drops it to a certain extent, that if there's a case of a loss, if there's a case of, let's just say, a breach, it doesn't impact the business, the hospital, or the healthcare organization to an extent that the cost of it is much higher than the loss. So that's the area that I would look into if I put any systems in place.
So with that in mind, I think that the senior, not as tech-savvy group amongst us would ask, how do we understand this in advance so that we don't do too much work or go down a path that's going to cause a lot of angst with those that are thinking about cybersecurity? What are you talked about the compartmentalization. How do you advise leaders to think about new programs or activities with cybersecurity in mind?
Okay. Go ahead. Okay. I think we have one advice. It's very important when we are talk with any department of cybersecurity in any hospital or any department. They said our challenge is the funding and the training. I think if we have a good training and we have a good funding, it will be will help us to have a good security, and we have good stuff. Also inside or internally of the organization, we should have a good awareness That's very, very important. Because you know, the attack, when they are coming to try to go to the any data or try to phishing, they are use the email and the links. So if we have a good awareness and we have a good training, we will have a good security.
Thank you. See, most of the time we are not proactive, we are only reactive. So only when attack happens, you know, we start spending. So recently, you know, there's a flood, historically 75 years, you know, this is the first time in Dubai, and immediately there's a sanction of $60 billion to make that, you know, nothing happens next time. So similarly, in an organization, we always look at it like, okay, when that attack comes, okay, we start looking at things. But as Sam said, you know, it's always a challenging aspect for an IT person to convince the management and get things done and invest on this. So it all boils down to money. You know, when you say that you have to spend $50,000 to $100,000 in a year, that's a red flag for the leaders. You know, what are we going to gain out of this $100,000 you spend every year? Do you gain anything out of it? But that $100,000, you say that 5 years you run it, $500,000 or $500,000, and then you might be attacked after 5 years. You spend $1.5 million. So as per the data, look at it on a checkpoint or a Sophos and some of the firewall statistics they have given, that $1.5 million and an average an organization spends. I would also say that it starts with the CIA triad, we call it in cybersecurity: confidentiality, integrity, and availability. So the confidentiality is just as a password protection. This is the most vulnerable thing in any organization, personally and the organization level. You still have passwords as 1, 2, 3, 1, you know. The least one which I can say is password is 1. I can give you the seriousness of this as an example. In 2021, US pipeline was attacked. There was a cyber attack. It was in Texas. So they were supplying the oil, southern part of the US. You know, they spent $4.5 million in Bitcoin. And you know the root cause of it? It was one of the users' password was leaked in the dark web. So they got access to that system and they stole 100 gigabyte of data, and they were able to encrypt, and then they started, you know, blackmailing. So it's a ransomware attack which kills the organization, in any organization in the world. So the ransomware is the topmost threat to the organization at this point in time. So I wish the AI can able to identify the ransomware and then it stops. So the ransomware is nothing but it just keeps encrypting the files across your network in servers and all your client PCs. I don't know, I haven't encountered any particular tool which can stop the ransomware attack because we always end up in a zero-day attack, we call it, that a vendor or a product company are not able to release the patch immediately. That's what is called the zero-day basically. So we don't have a tool so far to block this ransomware. We are mitigating it, you know, how do we assure that the organization is not going for a downtime for a long period of time, having a backup and then restore the backup and then get the system on board. So that's how we are mitigating. But we don't have an AI tool which stops looking at the ransomware and then stops that. Yeah.
Thank you. Well, I'll just iterate on all my colleagues. I mean, they covered a lot there. As management, you have to put the 3 triangles of management, which is basically operability, cost, and in the end, risk mainly. So you can't have all 3. You have to decide one. So either transfer that risk, accept that risk if the cost is quite high, but if you say, no, that risk is quite high, we'll accept, we need to mitigate that, we can transfer that risk, we need to eliminate that risk, then we spend more on the cost behind that. So that's why we choose what kind of security appliances is there. As for the cybersecurity triage, now the trend is quite different now. You can see that basically because of patient privacy is quite keen right now, especially for healthcare. So you also have the patient privacy as part of that. So you might not have ransomware, but your patient data might be leaked, and that would cause significant damage, not to your organization, but also as a nation itself. So that risk should be factored into that. It's all a matter, it's basically a formula seesaw. So the cost to the benefit ratio, you have to tread lightly and make sure that you don't miss any aspects behind that.
So along those lines, you talked about 6 aspects, and I think we'd be interested to hear more about the 6 aspects and how you go about ranking each of those in terms of which to address when and what you recommend.
Likelihood, definitely behind likelihood of that risk to happen, that's one. I would also rank likelihood to importance. So let's just say, would I spend a lot of effort and money, say, on a receptionist working station, although it's quite likely that that risk is quite high, but the data there is not that impactful? Or should I spend all my effort and time to basically make sure that the EMR doesn't crash, the HIS system doesn't crash, or the lab DICOM systems are up and running? So that's where the ratio is there.
So switching gears a little bit, I'd be curious over your careers, what have you guys been surprised about? Because you plan, you think, you bring in systems. What in the last couple of years has surprised you in the cybersecurity world?
Well, recently I can see, because of COVID, a lot of basically it's targeting not only healthcare, but it's also affecting supply chain management currently. And you can see a lot of trends in that due to Bitcoin and whatnot being untracked currency. So just this month, 2 high security threats, the top, it's like 10 out of 10, which is basically called RAT, Remote Access Terminal. And the other thing is, of course, people say do multi-factor authentication, basically have your password and say an encryption key that's triggered to that. Just recently, I think a week ago, was released that there is a new attack that just steals that away. So definitely zero trust is still the most predominant security framework to go through, because if any of that security framework that's been compromised, another layer takes in place. So mix and match of all the security aspects that are out there through those 6 fields that I just mentioned earlier. But also at the same time, you can see that whatever we knew that was safe and guaranteed is not there anymore. Not to mention adding AI on top of that. But on the security defensive side of things, having AI will increase your security aspects. So we have things that will see the trends, anything that deviates from the normal. Say you find Hamad accessing his data 1 in the morning. I never did it, say, in the past six months. So that deviates from the trend that's out there. So it'll trigger a lock and make sure that even if we miss something, the AI would put any anomaly into a quarantine zone and make sure that doesn't affect the security aspects of the hospital.
Thank you. What has surprised you?
Yeah. See, there are 3 surprises I can say. One is very predominant, that many people are not even aware of it, the cybersecurity. The second one is, they are aware of it, but they are not able to invest on it. The third one is they invested on it, but still not guaranteed. So these are all the recent events which tells you that AWS is attacked and Microsoft is attacked, and even these are the cloud providers, and they have been attacked, and there are service providers attacked. So when an internet service providers are attacked, our cloud system goes down. So we always look at it in a redundant connection, redundant internet connections. When we have remote places, the branches or different hospitals are functioning in the same country or a different country, you use that through the internet. And when internet goes down, completely the other places comes to a standstill. So these are the surprises I'm seeing, and I would say that just because it is not guaranteed that I don't want to be accused. And that's not the way to go for. We have to apply all the protocols and making sure that the organization is secure. So that's advice I can give.
I think Hamad and Lewis cover a lot of important things, but let me add one point. It's very important. When we talk about the policy is very important this in cybersecurity, and the different government they have the strong policy when they are talk about the like the Saudi Arabia who is working in the cybersecurity department. In the policy, they should be Saudi people only. So if you need to, and all of the countries look like this because we have the sensitive data and we have the a lot of things in this data. So when we talk about the policy, it's okay for the country. It's back to you. It should be have in the your policy, but you should have also, you should be ready for the funding, for the training, and for the you have the strongest stuff from your country.
Terrific. I have one last question, and if there's any from the audience. Just very quickly, what role do you think there is for regulation? It seems to me that most of our institutions sort of come up with an approach on our own with some kind of collaboration. What do you think that, speaking from your experience, is the role of regulation from your governments?
I would say I really appreciate the government here because NHRA and National Cybersecurity Center collaborated and partnered, and they helped the hospital sector here. They are also monitoring the infrastructure. If there is any threat to the organization, they immediately notify to the IT staff. So we got a lot of emails from them, and these are not like an actual threat, but they are able to identify that these IPs are coming from a different region, and is there someone else is getting into your system, and they're able to identify that, and they're doing it as a free of cost. So we are really, grateful for that. Moreover, as a HIPAA compliance in US, we might, have that kind of a compliance here for the healthcare sector. So that will make sure that every organization is looking at various cybersecurity tools and appliances on board, and making sure that their hospitals are secure.
We probably have a question. Anybody have a question from the audience? I think we're getting close to a break. So I don't know if there's any burning question from anyone. If not, I want to thank our panelists for really helping enlighten what is sort of a something with which we know that there's an issue, but exactly what it is and how to deal with it always seems very difficult to understand. So thank you for shedding light on this for us.
Thank you.
Thank you.
Thank you.
Thank you so much for this, the really discussion about this important topic. And I think the last question about rules of policy and regulation, I think even as a legislation in the Kingdom of Bahrain, we have a lot of laws and policies that really can regulate and help us. So with the permission with Dr. George, so we'll move to the last panel discussion. So we'll not take the coffee break, and unfortunately, but we'll have a longer break after that last session. And last but not least, I will come Dr. Deborah Birks again. It's our honor to have you again on the stage under the title of Evolution of Drug and Device Processes, Rapid Translation from Bench to Bedside. So we have Dr. Deborah Birks, and the panelists are Dr. Gabi Hanna, who's the CEO and the co-founder of Lamaso Pharma, and I think they are around here, and Dr. Rabi Hanna, who's the Director of Pediatric Hematology, Oncology, and Blood and Marrow Transplantation from Cleveland Clinic, who's a co-founder of the company, and also again welcome Dr. Stephen Hahn to the stage. So please.
I think they were expecting your coffee break, so let me. We're going to find them. You're calling, and you'll text Stephen. Okay. Don't worry. I can fill the time. I just want to pick up on something that Toby said, which I thought was really important about program improvement through data use. And I think the one thing that has struck me with every pandemic and every crisis is trying to convince people of the pandemic that they have, not the pandemic they want to have. And I think this was always true in HIV. People wanted a mommy-baby pandemic. And when it became, in Africa, an LGBT and key population pandemic, it was much more difficult for the presidents of the country and the prime ministers and the ministers of health to deal with that reality on the ground. But data helped us peel back the layers of onions to really move people's perception. If you're watching the statements from infectious diseases and epidemiologists again, we're back to where we were, where they're talking about the next pandemic will be flu. Remember how this pandemic was supposed to be flu? So we prepared in the US for the last 20 years a flu pandemic. And it was very difficult to move people who were committed to that preparation to a different virus that didn't act like flu. And we spent, and I don't know if this is true in the rest of the world, we spent oh, Steve, yep, come on right up here. We're going to get right into this. We're going to get the other two panelists up here. We spent the first couple of months trying to convince people about asymptomatic spread of the virus, and that it wasn't flu that could be followed through symptoms. And I think that when you prepare for the pandemic that you want, and that's not the pandemic you get, it's really difficult, and these were all scientists and these were brilliant people, it wasn't really difficult to move them to that concept of the pandemic we have, not the pandemic you want to have. Right now, again, they're talking about the next pandemic will be flu. We have to really be prepared for a pandemic that is not flu, as well as a pandemic that is flu. So I really want to get the other two panelists up here because we have a I know there's just a few people left in the room, but this is going to be a very exciting topic because we're going to talk about, oh, here they come. Great. Thank you. I know, they tricked you. Tricked you with no coffee break. That's all right. So this is a group that shares a real deep understanding of cancer and where we're going with cancer. But I think the COVID pandemic really pointed out, as we talked about, as you saw what Bahrain did, if you saw what all the other countries were doing with innovation around testing, let's just remember we not only had tests for hospitals, we had tests for every tabletop model that was found in clinics, and we had home testing for COVID. So within weeks, across the globe, there were tests being available so people could conveniently get to that answer, whether it was home, whether it was clinic, whether it was hospital. And we did that within a matter of 4 weeks at the US, but all of the countries were moving very rapidly because they understood that it was a crisis and we had to move quickly. And then within 3 months, we had multiple therapeutics, and then within 9 months, we had the vaccine. Cancer's been a big problem around the world for a long, long time. Why are we having trouble moving at that same speed with these new innovations with cancer? And I'll just go right down the row here. Steve, what's keeping us from being successful?
Well, you know, I think one issue now that I'm on the industry side is that the processes that we use to evaluate cancer drugs, cancer interventions are costly, and there are a lot of safeguards in place, and that's appropriate. But I think we can look to the accelerated approval process at the FDA, which has been used predominantly for cancer because it's an unmet clinical need, as a paradigm, if you will, of how we could apply the lessons from COVID to non-COVID problems like cancer. And so the accelerated approval process has in fact shortened that. Now it's still unacceptably long, but we've got to be willing, I don't want to use the word shortcuts, but we have to be willing to use non-traditional approaches to assess products and then use the real world setting afterward to further assess. So in the accelerated approval process, you use surrogate endpoints or intermediate endpoints. You don't necessarily use survival, which is where you want to get actually in cancer. So, but that allows you to get drugs to the market quicker so that you can look at them in a post-marketing setting for real-world evidence. So I think there isn't any reason why we couldn't do that. We did that with COVID tests, as you know. We did that with monoclonal antibodies. We did that with vaccines. The largest real-world evidence experiment ever in the history of the world were the COVID mRNA vaccines. Absolutely. Studied on 80,000 individuals in studies. 8 billion people got them, and we had follow-up data on them. So that's what we need to do for other diseases. And by the way, we need to do that for neurodegenerative diseases. We need to do that for autoimmune diseases, et cetera.
And interestingly, the world shared their vaccine data. So it allowed you to look across multiple genetics, which we're going to get into in a little bit, and the role that genetics play both in cancer response, as well as our immune response.
Yeah, I mean, I think also to add to Steve's point and what you discussed this morning, in COVID we shared data. You said within 48 hours you had data. So how great is, I mean, talking about cancer, sharing data. The FDA, like any cancer drug, maybe any class of a treatment, maybe there is 10, 20 companies working on one class of treatment. How great is that the FDA tell you right away, at phase 2, this doesn't work, pay attention, do this experiment right away. How good is that? How much gonna save time, effort, and cost? So that's part of that acceleration process that Steve mentioned.
Yeah.
Yes, really.
So this is because you're suggesting that the agency, the FDA, or a regulatory agency act as an intermediary, and I actually completely agree with you. There's no statutory, no legal reason in the US why the FDA couldn't do that. It's not been a traditional role, but if they were to access all the data from all the applications in a set of products and then give advice, you don't want to fall in this trap, you might want to design it this way, that would be very helpful. And again, really no reason, as long as you don't release confidential commercial information, that can't be done. So I'm with you.
Thank you. When you go back to FDA, Steve.
When I go back to FDA.
Maybe I can actually take back to your question to the basics, because I actually do think we have made great progress in the fight against cancer. And there are lessons learned from that we have to double down on them. And it comes back to sharing data. I'm going to give the story of pediatric cancer. Back in 1970, almost no one survived cancer except if you responded to surgery. And that's also brain, Dr. Cosgrove commented in a few minutes. Later, it was collected. All the children's hospitals said, this is rare disease, we have to learn together. So all the children's hospitals in the United States together, they formed children oncology group where we shared clinical trial data together and we learned together and expedited clinical research. So almost now 85% of cancer in childhood is cured. We need to do that for all types of cancer. That's really the first thing that we have to do in order for us to accelerate the speed of cure. Number two, it is really now the technology is allowing us to understand cancer biology way better than what we do, and we have to catch up in the clinical practice to what technology is allowing us in genomics and so many other immunology aspects, where I really think we are on the verge of newer and innovative therapy that can be more precise, and they can offer more cure by linking the data and the biology with the will So we can move from old way, which was surgery, to currently what it is, chemotherapy, immunotherapy, radiation therapy, to what my hope would be in the cancer future is prevention, because we do have some data to say so many of these cancers are germline, and we could potentially be able to predict who may have cancer.
I think what's always been interesting to me is this interaction between the host, the immunology of the host, and the cancer receptors. We've spent a lot of time defining the cancer actual receptors and antigens and its response to whether it's CAR T cells or chemotherapy or radiation. But we haven't spent enough time, and this really gets down to what Bahrain's doing with its genomics. Some of this could be very much genomic driven from the standpoint of the host and our own internal immunology. And I don't know how many of you belong to 23andMe. I made up people and put it in there. But 23andMe has more health data than we have. So millions, probably 1 billion people have given their data to 23andMe, and they're matching it up and saying, these are your risk factors. And we're not doing that with our own data in our healthcare systems to link up the genomic components with the immune response and the cancer types. And I think if we had put the same effort into generating genomics, human genomics with the cancer-specific antigens, we might be a lot further along with tailored therapy. Because what we're doing with chemotherapy is just hopefully killing the bad cells faster than the good cells. It's not really targeted that way. Radiation, same thing. I mean, there's a lot of post-damage from this radiation. I was really intrigued when I had a call with all of them talking about this importance of understanding the genetics of the cancer and the genetics of the individual and what it's going to take to bring the next generation treatment to bear, and what you all are thinking in your research about both the cancer genetics and the host genetics and the immune response, and what's holding us back from getting out new cutting-edge therapy.
Yes, so I'll whine a little bit and give my reason why I think this hasn't happened. Is one, it's been expensive, it's getting less expensive, and number two, it's hard. And you're a busy doctor taking care of 40 or 50 patients in one day. You can't possibly integrate all the information together like you need to answer these questions. So to your point, there is very likely some non-traditional somatic changes in DNA that are present that put you at higher risk for this list of 5 cancers. And combined with the right environmental factors, you are likely to get 2 of those. And then we can actually surveil for those. So there is, I think, in the genome, a rational way to approach that. But we also, I think it's important for us, like what's the transcriptome? What are the other parts of this, the metabolome, that also need to be integrated? And I have great hope that artificial intelligence and ML will be able to integrate those data in ways that we can't right now. Because I think that's where we need to get to. You're right, the host-tumor interplay, just like the host-infectious disease interplay, is very important. You guys just are way ahead of us.
And this is what Toby brought up on what it's going to take with this sheer volume of data. One of you talked about your tumor boards. And what I really think about is, I'm the oldest person on the panel, so I can say this. When I came into medicine, they had just discovered that there were B cells and T cells. And then they discovered childhood leukemia being derived from either a B cell or a T cell or a pre-B cell or a myeloid cell. It was revolutionary. That's how, and that was 40 years ago, and that's how far we've come. I think what you can do is leapfrog, and how you're trying to really figure out some of these things. And you talked about these tumor boards, but what do we do about places like rural America, where not only do they not have oncologists, they don't have a tumor board that knows how to sift through all of the genomics or the other information that they could get to really design the optimal therapy for that patient. So they're going to chemotherapy, or they're going to, you know, past treatments because they really don't have the ability to select the best treatment for that patient. What are you seeing in breakthroughs in those areas?
So I think I want to kind of take one step back to mention a few things and kind of before I address that. Maybe like 15, 20 years ago, when that genome is becoming very often, I served on the IRB for many years, and very commonly we see pushback from physicians. They see the genome data, they don't understand it, what is it? And if they have it, they tell the patient they don't want the liability, they don't know how to say anything to the patient, how to comprehend it. So there was gap in information. As the early morning you said, there is a double of information every 13 years for medical data, so the physician cannot catch up to the newest. And the other part is there is no tools available. Even if you understand those genome, understanding this data, you don't have the tools to give the patient what is the match, what the newest treatment, what is the monitor. So there is some gaps also how to apply it to real life. So if you facilitate these 2 points about understanding and then give them the solution, then it is ready to give to the physician when you apply this newest technology. I know, I mean, I'm glad. I'm involved now in a new company. We call it a new class of treatment based on the genome data. We hope my company or other class will be successful to bring that targeted therapy based on the genome component of the cancer cell. I know Steve is involved in a similar company to how to monitor, how to detect the best patient and how to monitor the progress or how to detect it very early. So I think it's coming, and I think now we're going to make it hopefully simple enough to apply those information to the clinical practice and to be able for any physician, when they get this data, they know this cancer has P53 mutation, MDM2, they know what type of test they're going to monitor the patient instead of the classic imaging every 3 months or biopsy. Now they know they have to do liquid biopsy to monitor it. Now they know there is a drug, hopefully our drug SADI will be available. They have to apply this treatment as the first class or second class. So hopefully now there's many companies working in the same class. It will be very clear to apply those new outcomes of this diagnosis.
Gabby, when you practice medicine in a busy day, even in a highly academic place, the data is accelerating at such a rapid pace that it is 73 days. You cannot keep up. That's why we have specifically molecular tumor board, not just general tumor board. It is really this data, it's becoming more and more complicated, and you may find multiple different genetic mutations. How do they even interplay with each other? You don't know. One of them could be a good risk factor, one of the other is a bad risk factor. And that's where I hope AI can augment our knowledge, can support us, because it becomes thousands and thousands of variables that we have now to support the physician. I think this is exciting time. We should not be afraid of integration of AI of this. Rather, we should try to embrace it to advance our knowledge. This is really, really important, not only the genomics, but we are learning more about the interaction with the microbiome. And by that, it is an additional level. That's why our environment plays a role even in our response to immunotherapy, what we eat, what are the microbiome in our gut. We give the same therapy and we expect the same result. No, we don't treat diseases, we treat patients. And each patient is a different combination of many variables. And we have to remember that. That's why we will need to incorporate all of that data together with the help of AI. And that will create a really more and more therapeutic option for our patient. And we shouldn't just think there's going to be one silver bullet. It's exciting. We went from now total surgery to more chemo, to more precise chemo. Now we have to put also immunotherapy, more precise genetic target therapy, and cancer could become a chronic disease.
Very quickly.
And then also we have to prepare our regulatory, because that's going to add to the cost. This is when you ask me about why we are not embracing it, because honestly it's cost is a big barrier of it. When we are expecting to offer all of these therapies to many patients and we prolong their life, there has to be preparation on the cost that it is going to be down, kind of the pathway on our payer and our government, that it needs to be taken also into calculation.
But we have to remember the cost might be less overall if we treat each patient with the right therapy and then they're not having relapses, rehospitalization.
Right patient, right therapy, right time. You got to believe that if you put precision medicine when it's supposed to be done, I certainly believe that it'll save money. Just really quickly, a point of hope. I'm advising a company in the United States that is putting together a very beautiful platform with an inference engine around exactly what you just described, which is of the hundreds of cancer drugs that were approved last year by the FDA and all the companion diagnostics. When you have a patient come through the door with, say, metastatic endometrial carcinoma, and you don't, your first thought is cyclophosphamide, natriamycin, that sort of standard approach, when in fact they have the appropriate genetic mutations to get Jemperli from GSK, which is a really good targeted therapy. This inference engine tells you, doc, you need to order this. The insurance companies allows you to order from this. When you get the answer back, they will rank order the results based upon NCCN ASCO guidelines and say, these are the recommendations in terms of therapy. There's no way a doctor in practice in Alabama can do that.
So when do we get that, Steve?
It's available now.
It's available now to everyone, or?
No, it's focused on rural America, as a matter of fact, which is why I like it. Anyway.
I feel like we have opportunities that come by us. Right now, we had the opportunity to really figure out long COVID. I think if you ask people to come forward that had long COVID for genetic analysis, I am sure we would find a relationship between the different long COVID symptomatology and specific genetics. And that you could then, because there is an impact with vaccination, there is an impact with Paxlovid, and that combination may decrease their risk by, say, 50%. And so right now we have a problem across the globe with long COVID, but we're using we're not asking people to come together, we're not asking to share genomic sequences, we're not matching symptoms and pathophysiology with genomes, and we could do that today. And then the globe would get used to seeing that genomics is good. It can be used for good, rather than everybody worried that we're going to do some secret analysis on their genes and tell the life insurance company not to insure them. Because I think there's still people who feel that way. But I think, when we have these, there's millions of people with long COVID right now. And yet, now there were billions of people who got infected. So when you have millions, you have to assume it's some kind of specific driver. And since everybody more or less got the same virus, the same variants are circulating across the globe at any one time, moving around the globe, and it doesn't look like there's specific variants driving it. So you could try to figure this out, but there isn't like a global call to action. And I know for the long COVID patients that I have and others have, there's a level of desperation now, years into this, that we have technology, but we're not bringing it to bear. How do we reassure patients that we're doing that for cancer and some of these other intractable diseases, that we're really putting our brains together across the globe to work on these and not in stovepiped either countries, or I loved it when Toby talked about what did you call them? The guilds. The guilds where we're not having different subspecialties talk to one another. How do we open this up to a global information pattern rather than a US or European-centric pattern, which may not represent the most of the genomes in the world?
Well, I'm not quite as optimistic about that one. And I think it would be important, and I think it would help. But at least in the private sector, there's capital at risk, and there's competition, and there's the desire to get your product onto the market. And so that's somewhat inhibitory. Now, that being said, I know with our company, for example, we are very interested in gathering information on the genome across racial, ethnic, and certain environmental sort of situations, because we know that we have our own data that shows that affects the genome. So I think it worked in COVID, during COVID, because antitrust rules were relaxed and people could collaborate. That's a nut that needs to be cracked. I don't have a good answer for that, just to be completely honest with you, and I'm less optimistic about it.
Dr. Briggs, despite I am always optimistic, I feel I have to, given being a pediatric oncologist, but this is where it brings me sadness. I think there is no will to do that. I think one of the things that we learned during COVID, it's important to adjust the regulation to the needs of the patient population. One of the best things that happened was the ability to do telemedicine across state borders. I can't tell you how many patients we gave them the correct diagnosis, adjusted treatment, gave them hope when there was no hope given to them. For us to move toward getting it even in the United States, rather than even globally, I don't know that we are there yet. There are so many barriers that we have to overcome. There is also the barriers of like research and the data we collect. We have to think differently about health disparity. We have discrimination even in the United States based on where's the location of that patient that will limit their access to really novel therapies, their access to true. For many years we were thinking patients who are African American or Hispanic will have much lower survival with AML as an example. Recent data showed us that if we could adjust their chemotherapy based on their pharmacogenomics, we can actually achieve the same level. Many of the data and the doses that they came from the clinical trial is based on what was patient enrolled on a clinical trial, and we see a huge difference between the participants who are Caucasian versus African American, and we assume that they are going to metabolize the same data. There is so much more to do in terms of getting better representation, inclusiveness in our data that we get so we could make better therapies in the United States before we even make it globally.
It was very interesting to me how that got politicized in COVID, because when this happened, I went out on the road. I sent Steve out on the road. We went to very rural counties all across the United States to figure out what was going on. And I think, to be honest, I had spent 20 years building resilient health systems in Africa with data to respond to the HIV epidemic. And in many countries, we have 95% of the population tested and virally suppressed. Way better than the US, and it didn't matter where you lived. You could be in rural Africa at the end of a road, or you could be in an urban area. When I went back and looked at the data, we have been reporting higher fatalities across every age group in rural areas, and now it's 20% greater, age-matched controls, rural versus urban United States. And we had been mapping it for more than a decade. COVID hit, and we said, oh, well, the reason COVID deaths are higher in the rural areas is because how they voted. You know, it immediately said, oh, it's how people voted, not the discrimination of less health care. When you close a hospital, you lose all the primary care physicians as well as the subspecialists. You don't just lose, you just don't lose the subspecialty medicine, you lose the family practice. I was just in two rural clinics in Texas, and they have one family practice physician in the entire county, and that one's retiring. And the hospital is being run superbly by nurses and nurse practitioners, and they've been doing task shifting. But I mean, we cannot sustain this. The fatalities are higher. I'm sure they're higher for cancer. They are for every other disease. I found the highest incidence of end-stage renal failure on dialysis because of undiagnosed diabetes for decades. Yet, we're just tracking the numbers and not acting on the problem, and then we're making it sound like it's almost their fault that they live in a certain county and vote a certain way. What can we do about that? I mean, how do we get the data that you're talking about, these solutions to rural areas, seen at the decision makers, the policy levels, so that they understand that it's lack of access and not how they voted?
Well, I'm more optimistic about this.
Okay, good.
Yeah. And it's not like being pessimistic about the other one. There's not a solution out there. It's just that there's a lot of incentives that aren't aligned, that's for sure. But I actually think this is what you described that you did beautifully in Africa and the time we spent in a cancer program in Botswana. There are lessons to be learned there about how you build that resiliency and how the sort of one-size-fits-all approach that's used in New York City, maybe Cleveland, isn't an approach that will work in rural Alabama or New Mexico or wherever. And so I think alternative care models are important, but I also think, you know, the use of telemedicine and technologies to bring what the molecular tumor board says in the Cleveland Clinic to the folks in New Mexico, is that those are eminently solvable problems. We just have to be able to invest in that. Now, I personally think that if we incent the private sector to solve these problems, they'll be solved. And that we have to create the regulatory and legal framework and then provide the resources to get it done. But I do believe that the answers are there. They have to be applied. And we have to ask government to create the framework to allow it to be solved.
I think we need to have vision and the goal of what we want that care to look like, and then with the leader to execute that vision. If we want the vision to be world-class care to everyone in the United States or globally, we then have to put our resources where our words are. And that words start with the regulation. I think it is technically all of these issues, there is a solution for them actually. Right now, with many of the companies that they do sequencing, it's becoming very affordable. It's very possible to do all of this data. It is possible to translate that data to the electronic health record number, and I would assume, I'm not familiar with the all AI application, that there could be possibility of some recommendation or something like this. This could be done, but it is facing against the barrier of the silos that they are currently exist in our healthcare system, that we need to break down the silos. And I will go back to that vision to share with you the sickle cell disease history. Sickle cell disease is one of the inherited diseases that was described in 1921. There was no medication except hydroxyurea that was authorized in 1981. Then Dr. Francis Cohen, who was the head of NIH, he came in 2004 saying that we need to attack sickle cell disease and cure it similar to what it we cured. And he initiated in 2009 what's called Cure Sickle Cell Initiative, and with money and funds, within 10 years, from 2009 to 2019, there was 3 new drugs. 2022, there was now gene therapy approval for that. We have to invest, we need to support our vision with the resources, and that could translate that solution to reality, that it could provide access to many of these patients.
I will add one point. I don't know how government work kind of to build up, but I have no experience like you had, Steve. But I would say learn from mistake and experience. I mean, the same conversation in cancer, we started it 9 years ago with Moonshot Fight Cancer during then Vice President Biden. And one of their goals was to share data and to collaborate with the private sector. So the same conversation we had it, and I forget how many billion they announced that time, but obviously that didn't pay the result with hope. Now I'm sitting as CEO of biotech. I don't know what the lesson learned from that experience exercise. I don't know if anyone learned that mistake to build upon on that experience and to prepare the next solution from government, regulatory, and even private sector, which I present one of that angle. So I think that's learn from that past experience and give that solution to advance on it. I think that will be also a big advantage for us.
You could make some data sets that are currently private, you could make them public if they're de-identified, et cetera. You could, because there's a lot of data in publicly available data sets to mine, particularly around COVID, to answer the question that you're asking about long COVID, and we could answer that as well in cancer, I think.
Yeah, and the way we de-identified, because all the data for all, we have about 55,000 sites across the globe in PEPFAR, and we can see every client at those sites and whether they're virally suppressed. And the way we de-identified data is we created age bands so that you couldn't tell who's who. So, you're 40 to 45 or you're 46 to 50, so that we could look at by age our success, by gender, and see where we were in success. And I think we haven't talked about this in this panel, but it's hopefully something you all are talking about all the time. I've heard it kind of referred to, is a real problem with men accessing healthcare, even when it's available. And we saw that all through sub-Saharan Africa all the time, that they aren't going to go unless an arm breaks or a leg breaks, and then they'll go and have it fixed, but they're not going to go. And we were not getting any young men on treatment, and you can't stop an epidemic when you're only finding the women. And we found the women because we had great PMTCT pregnancy programs. So there was a high rate of pregnancy, so we found the women, we didn't find any of the men. I had to call in the private sector and say to the private sector, help me figure out why I can't find the men. I've talked to them, and they said that, they want male nurses. I did that. They said they wanted early hours and late hours on the way and from to work. I did that. They said they wanted male physicians because they thought we were gossiping about them. I can tell you, we've never gossiped about a man in our clinic in our lives. So we fixed that. Still, they didn't come. Finally, the private sector found out that men trust one person in their lives. And it's not their wives, it's not their children, it's their mother. I knew where the moms were. The moms were in church on Sunday. So we took self-tests to the church. We explained to the moms that their sons needed to be diagnosed no matter what age they were, and they needed to get on treatment immediately, and we could really help them, and they would thrive. And we got 2.5 million men on treatment in the next 24 months. So it's finding that one connector, and there always is one out there, and this gets to why don't we listen to men when they speak about what they want, and I wouldn't have thought of asking that, but there are people that sell to men, and they know what drives men to access certain things, and I think we could learn stuff from the private sector about how to really decrease the barriers to groups that we know don't routinely access healthcare. Now, this is the time for you all to ask questions of this incredible panel about what you're doing in your country to ensure access to cutting edge cancer treatment, access to cutting edge genomics. Ask or provide a comment. I know you're still awake out there. I see you. I see your eyes, so I know you're awake. Yes. Toby.
Does the FDA have to set up a new section in order to begin to credit the various new technologies that are around AI?
They don't have to.
But
the question is, should they? Yes. And again, I don't speak for the FDA anymore, but I actually think it's a really good idea. And one of the problems with the FDA, as you probably know, is it is as siloed as it gets. And where AI ML sort of sits right now is in a center called CDRH for devices and diagnostics, in vitro diagnostics, et cetera. And we know that that's now, sponsors are coming forward in biologics and drug development using AI ML, and it's a bit of a black box for folks. So yes, a cross-cutting very similar to the Oncology Center of Excellence, which cross-cut across all of the centers, would be extremely helpful with respect to that, because the technology, the expertise, et cetera, needs to be in-house for the FDA to feel comfortable to adjudicate decisions. And if they don't have that, it's going to slow it down. So I think it's a really good idea.
You know, you could learn from what they did at the Cleveland Clinic, is suggest that the FDA bring people together rather than this way.
So we could have learned from Deb Burks and the bringing of Palantir to collect data across the country. There's another one that could have been learned, because that's another important part for the agency, is the infrastructure that's not there.
I'm going to go back to the point that Gabby brought up about accelerating by knowing the data and what others have done. Steve, you agreed with them. Could they at least release the data without allocating the data to which company has done what? Because companies and lawyers are going to really make it very hard for you to release this data.
So I'll just use as an example the approval of the aducanumab for Alzheimer's in the US and the controversy around that. The FDA went to the very, very extreme lengths of releasing a transcript of a conversation that occurred in-house, where it was very clear with what they had gone back and looked at other applications in the same sphere. So without obviously naming names, they said, we went back, we looked, we saw these patterns, and that led us to make a different decision this time for this drug. And so yes, I think it's possible. We've seen that as a little bit of a glimpse that perhaps, certainly it's happening inside the agency. It would have to be carefully done. I'm not a lawyer, and so I can't tell you what's in statute to prevent it, and they'll probably use 1,000 excuses not to have that occur. But I actually think it's a terrific idea. To Gabby's point of, you know, what could we let folks know has been experienced to actually not make the same mistakes again, and either fail early or succeed early. That's true too, right.
I think the other thing that would be really helpful is, you know, they often will talk about pivotal trials, but what would be super helpful are phase 2, phase 2B trials where people didn't go forward, rather than repeating that technology and mistake. That would save us probably a decade and billions of dollars if people would tell us what phase 2 and phase 2B studies didn't have enough biologic relevance to move forward. That would, the great thing about COVID is we were honest about what was failing. People across the world were trying different things, and they were being as honest as they could about what looked promising, what didn't look promising, and that really helped accelerate a lot of different ideas. We're just not doing that across other diseases. And I think if we would know what phase 2 and phase 2B studies didn't get to the biologic relevance piece and why, then we would leapfrog to that new place. Other questions, comments? Yes.
I was going to start, and then Dr. Toby, and then you completed. My name is Naim Al-Qasir. I am Bahraini, and I've just come back to my country after 26 years serving in the WHO. Thank you very much, Dr. Cheriyan, for having me here, and the whole organizer, including I've been nominated by Emcee. While sitting yesterday and now listening to this, I would like to list 3 things. Yes, it has taken 2 decades to become using the AI, but when it comes to your question on what shall we do to have this sharing, a lot is learned from the COVID-19 that we have not applied. We went back to our normal before and not new normal.
Yeah.
And the partnership that happened to accelerate for medicines, for vaccines, for diagnostics, bringing key willed partner, politically committed, including investment of funding. Everybody came in solidarity from $1 to billions. And this is something that I did not hear today. Non-communicable diseases, cancer is hitting everyone. And that's where I was going to question. If we are not happy with the current multilateralism and the partnership of the COVID-19, where we were able to bring the scientists around the table almost every other day to speak, to bring solutions, how can't we do it now? These are some of the lessons also we need to reflect, especially that this forum is talking about future health services, healthcare and not sickness, and it's talking about keeping people healthy, not always patient. How are we going to look into this? And these are some of the questions that come to my mind.
Well, I think it's a really important point. So I'm going to ask you, because you spent all that time at WHO. Why doesn't the WHO, because the reason many of us made progress is because the political people, the governments were talking to the private sector about what they needed.
And communities and scientists.
Yes. So the WHO talks to communities, they talk to scientists. Why aren't they always bringing the private sector to the table and saying, we need solutions, this, and this, and have the private sector there? It's like they're allergic.
Okay. WHO are member states, including USA. The governments are making the decisions. I served as a civil servant. So this is something that needs to be looking at. Who is making decisions on where to go, what happens? Whether it's G7, G8, G20, or the World Health Assembly, the government.
No, but when the WHO puts out their guidance, they're putting out guidance internally.
Yeah.
But they could, when they're developing that guidance, have the private sector there for 100%. Feedback. They are, I can tell you, they are never there.
I am a non-traditional WHO. I am someone who served in Iraq in 2003, and the first thing was happened the telemedicine that we had to really test, and we were told in 2 years it will happen. So I am someone who started in trying to work in a complex situation, serving the people. So I am not traditional, quote unquote, WHO, but I want to go, when I said member states, because not to work with the private sector is actually a decision by the member states. So someone like me who is believing in partnership, bringing everyone, engaging, integrating, bringing everyone around the table will have difficulty. I was able to move something because I just closed my eyes, playing innocent, playing young, playing doesn't know the whole rules, and bringing around everybody to the table, including the ones who are against or with private sector, non-private sector, and we could move. And that's what happened in COVID. And today, when you talk about agencies from the state, United States, not everybody will understand. So when we are, Steve, we are talking about agency, FDA, and I talked about CDC and others, in other countries are imitating what US is doing. Mm-hmm. Your silos are being replicated. Whether we like it or not, it's being replicated. So we look for best models, best solution. And you were rightly said, I think you were the one who said there is innovation, that people are coming to United States, or actually Dr. Toby, for innovation, for new things, for opportunities, because they see we could move. It's time to bring the East, the West together, and that is something that I learned all day today, that we are talking the same language, almost, but not understanding it and not yet complying it to it. So this is something that I want to go away. Multilateralism, partnership, what does it mean? And what you beautifully stated that morning, and now you repeated, the horizontal, the vertical. How are we going to bring them together, but with a new look? It's time for a new look. Whether it's WHO or other agencies, as Ambassador said, we are all striving for the same thing. How can we think differently and not repeat what we have been saying to each other the past few years, especially with COVID-19 now that it hit us? So I'm raising the questions. I don't have the answers, but I think it's the paradigm shift that somebody talked also earlier, to think differently.
Well, I think we have a great case study from Bahrain, yes. Where they've really, and I think what we should probably have is the member states come forward with their case studies of what worked and what didn't work. And I think once that theme is there, then we might get some
and
movement.
The partners and the private
yes.
sector, and the balance between for-profit, but at the same time meeting the peace and meeting the commerce and protecting the climate, which tomorrow I think somebody will be speaking also about. Thank you.
Great. Thank you all for participating. I really appreciate your comments and your questions. It makes the panel so much more vibrant. Thank you all for the work that you do in cancer. listening to them on the telephone, on a Zoom a couple of times, it really convinced me that we're in good hands when it comes to cancer, of what you all are thinking about and what you think the next steps are over the next 2 years. I think it's incredibly exciting. It's just a matter of us implementing these visions that you all have. Thank you so much for doing this.
Thank you so much. So I think, you know, we are coming to the end of the day. So thank you all, really thank you. We really appreciate it. That I hope that you all enjoyed as much we enjoyed all the discussion and the insightful, you know, thoughts that has been going through the day. And I hope that's been an eye-opener, and we have critical thinking to think where we are now, where we want to be, and the ultimate objective, which is the best quality of care for our patients. So I'm calling now Mr. Ransel and Dr. George for the closing remark.
Well, I'm not going to keep you all long. You've been a wonderful audience. You've been a wonderful group. I have to tell you that it's been a wonderful day. I've listened, I've learned, and I've really have discovered that it takes really communication and collaboration with everybody sharing ideas. And that's really what C3 is about. The mission is really about knowledge transfer. It's about healthcare diplomacy, but most importantly, it's about thought leadership. And there has been so much wonderful thought leadership here today that I hope I can put it in a bottle and repeat it tomorrow. So thank you all. It's been wonderful. Please come back, because we have a second day of more exciting and more interesting panels with really very interesting folks. So thank you again, inshallah.
Thank you again. I mean, we've got the diehards in the auditorium now, but I just want to sort of briefly summarize the learning points that I gleaned from attending, you know, all of the sessions. It started with healthcare in crisis, cost, workforce, and data. And we heard so much about how data can be used to further healthcare across the world. We then talked about a paradigm shift. And this big paradigm shift that's happening in healthcare is how we flip from sickness care to healthcare and preserving health, because that's going to be the future of health. And we certainly heard that in the last panel, how beautiful it would be if we could actually detect cancer before it becomes manifest, and then prevent it altogether. And now that's an amazing thought. Then we talked about the future of training of our workforce, which is in dwindling supply, and how do we prepare the workforce for the future in a world of augmented AI, ChatGPT-4, and all of that that's going to hit us. And finally, how does innovations really reduce costs? I mean, you know, we see it in presentations and people talk about it. You know what? Good quality should save money, innovation should save money. But when it really comes, when the rubber hits the road, a lot of people are still struggling. And Toby gave the statistics. Most public-private hospitals, they have a margin of 0.3%. And even this is dwindling, and we need a margin of 3.5% to stay in business. And it was shocking for me to hear that about 460 hospitals in the US is ready for closure because they can't meet the margins. And that's frightening. And that's not true just in the US, by the way, that's true in the GCC as well. There's an oversupply of beds that cannot be staffed because we don't have adequate workforce. And so that might be a problem in this part of the world as well. And finally, the physician empathy part of it. Toby, I have seen that video that you played several times, and I have used many Kleenexes, and I'm not ashamed to say that. And every single staff member at the American Mission Hospital at one point was forced to watch that video. And not only that, we created a similar video on the American Mission Hospital exactly on the model that Cleveland Clinic created it, because for us, our value statement is compassion, grace, and love. That's our values, and everything that we do is on that anchor. So that was deeply moving. Even though I must have seen it for the 25th time, I teared up when I saw that. Thank you for flipping patients, physician-centered care to patient-centered care, because that's what we're all about. And finally, precision-based medicine. Precision-based medicine will truly create the value-based healthcare that we all are talking about, because it is not that one bullet is going to cure everything, but we will find the magic bullet that will hit the patient for what the disease is all about. And finally, Rabbi, I'm with you. With you when it talks about, collaboration is the only way forward. We are too siloed in the way we have approached medicine, and we are talking about global healthcare. We are so siloed that we don't share data. And I will finish with a brief story. With me in training in pediatrics, 1982, I was a fellow at the Hospital for Sick Children in London. We had a 9-month-old baby, the baby of one of the twins of a diplomat who was based in the US for 3 years. This baby was born at the Children's Hospital in DC as a premature baby, stayed in the unit for 2 months, and sure, the twins were discharged. And at the end, the ambassador was, reassigned back in London. And I was the fellow that admitted this baby at the age of 9 months with a very peculiar pneumonia. And the initial diagnosis that we diagnosed the baby with severe combined immune deficiency, because the baby had a pneumocystis pneumonia that we identified on lung biopsy. But then the father said, look here, the twins have been in the unit in DC for about 2 months, and they had just broken news that there was contaminated HIV blood that was used in the unit. And we had not seen a single case of pediatric HIV in the UK till that point. So one of our immunologists got onto the phone, spoke to someone in DC, and sure enough, we tested the baby, and we had our first HIV baby in the UK in 1982. So this is what collaborations does. We could be siloed in our own little ivory towers, not sharing data, not sharing knowledge. And there is no way we can push the healthcare agenda to make it equitable and accessible for all. This whole forum is based on how we make healthcare accessible and equitable for all. We've got the best brains, in this room, sitting here. And yet, unless we collaborate and share, and that's what Ransel, thank you for C3. This collaboration across communities, that is the only way we impact communities. And I'm a very passionate visionary on that. And my whole life is dedicated to finding solutions for, as a not-for-profit organization, for allowing this high-tech care to be accessed at the bottom of the pyramid. Many of you work in ivory towers where your research touches the top of the pyramid. But it is the top of the pyramid that needs to change care for the bottom of the pyramid. And I think with collaboration, we can make it happen. So thank you for your attention today, and I look forward to tomorrow, where we will be talking about innovations, and hopefully sustainable innovations. Thank you. There is a reception this evening. Please join us. For those of you who are in Bahrain for the very first time, I know it's been a long day, the weather is beautiful outside, so take a run or a walk outside. The temperature outside is beautiful, and we will see you later this evening and tomorrow morning. Thank you.